Good morning, everyone. We're going to go ahead and get started, if we could. Thank you. All right, thank you. Are we good online? Cody, are we ready to go?
Yes, we're ready. Thanks.
Thank you so much, Cody. Good morning, everyone, and welcome to the Mental Health Services Oversight and Accountability Commission meeting. My name is Mara Madrigal Weiss, and I'm the chair of the commission. I want to thank you for attending today's meeting. At our January 25th commission meeting, we approved the commission's strategic plan for 2024 through 2027. Cody, can you please bring up the strategic goals slide? The slide reflects the Commission's goals as outlined in its strategic plan, which continues our commitment to advancing the vision of well-being for all Californians. Today, we will be discussing new transparency and accountability opportunities under Prop 1, how the measure impacts the Commission, our progress in drafting a strategic plan for early psychosis intervention, and our budget. These topics align with our strategic plan goals to champion vision into action and relentlessly drive expectations. You'll also notice that many of the agenda items have icons next to the titles. These icons represent the strategic plan goals associated with each agenda item. Thank you, Cody. Now we will take roll and establish a quorum. We would like to note for the record that we currently have a quorum of 8 commissioners in person. We have 1 vacancy on the commission and 1 commissioner currently on leave. Therefore, under the Bagley-Keene Open Meetings Act, 8 commissioners in person are needed to conduct business today. Also, under a change in the Bagley-Keene Open Meetings Act, any commissioners who are participating remotely will be asked during roll call to disclose if they have any other adults over the age of 18 in the room with them during the meeting, and the nature of their relationship with these individuals. Sandra, at this time, would you please take roll?
Certainly. Commissioners, please unmute your lines now for roll call. If you're participating remotely, I ask you that if anyone over the age of 18 is in the room with you, per Bagley-Keene, to please identify them. Additionally, you must remain on camera if you are participating remotely. If you need to step away or go off camera, please do let us know. I will now proceed with the roll call. Bontrager.
Here.
Brown. Here. Bunch. Carnevale.
Here.
Carrillo. Chambers.
Present.
Cortese. Danovich. Gordon. Mitchell. Robinson.
Present.
Roulette. Vice Chair Alvarez.
She's waving.
She's waving. Okay.
We'll go with here.
Chair Madrigal Weiss.
Here.
We have a quorum.
Thank you, Sandra. We are now moving on to agenda item 2, announcements and updates. Before we get started with announcements, I want to note some changes to the agenda format and layout that we're made to support transparency, community participation, and adherence to changes in the Bagley-Keene Open Meeting Act. On page 1 of the agenda, we clarify that our meetings are both in-person and virtual. At the top of page 2, we state that items not listed on the agenda will not be considered by the Commission unless there is an emergency. And at the end of the agenda, to ensure multiple opportunities for public comment, we have created an email address to submit public comments for Commission meetings. The new email address for public comment is publiccomment@mhsoac.ca.gov. Any public comments submitted via email will be distributed to the Commission members prior to the following Commission meeting, pursuant to the terms outlined in the agenda, and will be included in the meeting minutes. Now, I would like to begin this morning's meeting's announcements by sharing that July is National Minority Mental Health Month. Cultural ethnicity and race all play a role in the way that each person experiences the world. These factors, among others, have profound effects on mental health, especially for Black, Indigenous, and people of color. Still, not everyone has equal and equitable access to these crucial services because of stigma, shame, or fear of judgment. These factors create significant barriers that prevent individuals from seeking mental health care. I want to thank commissioners, commission staff, and all community members in the audience and online for elevating the voices of those in our communities that have been historically marginalized, ensuring that no one is left behind. Through education, advocacy, and community support and empowerment, we can create a future where mental health is a priority for all. Also, another announcement, Governor Gavin Newsom has issued a proclamation declaring July 2024 Disability Pride Month. With this proclamation, California joins communities around the nation in recognizing July as an opportunity to celebrate the many ways that people living with disabilities, whether visible or invisible, mobility or cognitive, add to the diversity and strength of our state. Diversity, equity, inclusion, and accessibility are integral parts of the Commission's ongoing work, and I invite you all to join me as we reaffirm our commitment to the rights and independence of disabled individuals in our communities. As part of Proposition 1, the state has established a revenue stability work group. Jointly by the California Health and Human Services Agency and DHCS, the work group will develop solutions to address revenue volatility and support the sustainability of county behavioral health programs. The work group begins today and will submit its recommendations to the legislature and governor by June 30th, 2025. As Commission Chair, I am appointing Executive Director to represent the Commission. So thank you, Toby, for taking on this role. If any commissioners are interested in participating in the work group, please let me know. Due to today's Commission meeting, Callie Patterson will be stepping in for Toby so he may attend the Revenue and Stability Work Group on behalf of the Commission. The Commission was invited to the Golden Gate Bridge Suicide Deterrent Commemoration on July 15th. This event is a celebration of a long-awaited suicide barrier built to reduce the number of deaths resulting from jumping off San Francisco's Golden Gate Bridge. The Commission provided seed funding for this project in 2017, with additional funding from other state agencies and federal and local partners. This project is the culmination of a tireless campaign by families who lost loved ones at this iconic site. As of January 1st of this year, the net now runs the full 1.7-mile span of the bridge and has already saved many lives. The Commission is proud to be part of this project. Continuing on to the topic of suicide prevention, the Commission was invited by the California Legislature Native American Caucus to participate in a roundtable meeting with tribal leaders and community members, along with officials from California's Office of Suicide Prevention, to discuss the critical issue of suicide within tribal communities. And as you may recall, Prop 1 modified the design of California's Behavioral Health Innovation Strategy. So beginning 2025, the Commission will receive $20 million each year for a minimum of 5 years to invest directly in behavioral health innovation. Commissioner Carnevale has been exploring opportunities to strengthen behavioral health innovation. He led a site visit to UC Berkeley in June and was accompanied by Commissioner Bontrager, Commissioner Chambers, and Commissioner Robinson. This site visit included a tour of the CRISPR lab where Jennifer Doudna, Berkeley's Chair of Biomedical and Health Sciences, conducted her groundbreaking work in DNA modification, as well as a visit to UC Berkeley's SkyDeck and Venture Lab incubator programs to support innovation. The Commission has been invited back to UC Berkeley this fall for a roundtable meeting to continue the conversation with the incoming Chancellor Rich Lyons and other UC representatives. Building off our work on innovation, prevention, and community engagement, the Commission was also invited to send 4 representatives to London to engage with UK behavioral health leaders. Commissioners Carnevale, Brown, and I, along with Director Ewing, met with UK leaders to explore shared learning opportunities on innovation, education, safety, public-private partnerships, data analytics, outcome-based contracting, and more. We are exploring additional opportunities with the United Nations and the Clinton Clinton Global Initiative in New York this September, again with our UK partners in October, and the Organization for Economic Cooperation and Development for a meeting in Rome in November. Commissioner Carnevale, please share a bit more about these opportunities, what we have learned so far, and what you see as our next steps. I would also like to invite other commissioners to share their thoughts on the site visit or who may have comments about these exciting opportunities. So I turn it over to you, Commissioner Carnevale.
Thank you, Madam Chair. I'm actually reading from some notes because we've done a lot, and I want to make sure I've captured everything, but there's a lot here, and anyway, well, let's get started. Just to frame this, last year, Madam Chair asked me to explore the opportunities for the Commission in innovation, and that was a natural outgrowth of the leadership I provided to the strategic planning process. And part of that was in context of the state's approach to shifting innovation for mental health. In crafting Proposition 1, the governor highlighted opportunities for public-private partnerships to increase innovation in behavioral health. So the private sector, including philanthropy, is currently investing tens of billions of dollars in behavioral health innovations, but much of that is likely to expand the gap between the people who we serve, who are well served in the insured system, and the private system, the people who are not, that we're focused on. We had extensive conversations specifically covering capital innovation to dramatically increase the amount of private capital that can supplement the public sector investments and improve outcomes for people, which is really a key part of all this work. Just like we have seen with climate change and with other social issues, government alone cannot solve these problems. In my discussion with the governor and his leadership team, it's clear that we have an opportunity to focus behavioral health innovations on addressing these disparities, and there's a tremendous willingness on the part of the private sector partners to make that happen, so that's really what we're trying to explore here. One challenge they have is not knowing how to best work with government, because government is very complex. The Commission is uniquely positioned to address that opportunity and facilitate solutions for those groups to come together and collaborate and serve those who need it the most. These groups include clients, family members, providers, public officials, educators, law enforcement, business, labor, research, many. And we're well positioned to facilitate that public-private partnership that can improve outcomes for people and for the system itself. California has taken the lead in the nation in many areas in prevention, early intervention, comprehensive care through full-service partnerships. And yet we fall short behind on addressing homelessness, addiction, addressing early psychosis care, and more. So, we have a lot of work to do here still. I know from my personal experience that our crisis response system can be phenomenal, and yet they can still fall short. The people who work in these systems are everyday heroes who go unrecognized and unrewarded. Through no one's fault, the system is structured in ways that challenge everyone, and I know again from my personal experience that innovations can fundamentally change how we meet these needs. We have the power to make their jobs easier, less frantic, and at the same time improve our system, particularly around preventions and early interventions. I can tell you from my activities, including the most recent trip to London, that California is gaining international recognition for the work we have done and what is possible to come next. And we saw that, I think we all saw that in London. I appreciate the support of the Commission in facilitating conversations with potential partners that can help us drive this transformational change. Toward these innovation goals, last month I organized the following events. Madam Chair mentioned UC Berkeley, which included the CRISPR lab. Jennifer Doudna gained a lot of recognition as the founder and the Nobel Prize winner. And we're exploring how we can harness that capacity for their gene editing from this famous research university to turn their attention to behavioral health. The new incoming chancellor, Rich Lyon, interestingly, was the head of innovation at Berkeley, and then they elevated him, was with us at the end of the day and offered to partner with the Commission to explore all the opportunities across biological research, genomics, innovation, and entrepreneurship, and which they lead in all of those areas. And the vast majority of what we saw in our visit was funded with private dollars related to startup funding and grants and others. So it would be silly not to engage with Chancellor Lyon to try to see if we can harness that more for our behavioral health system. I had the honor to lead the commission delegation to London with Chair Madrigal Weiss and with Sheriff Brown, and we thoroughly we worked very hard. We were working from morning to night on that trip, even though it sounds so glamorous. We participated in a knowledge exchange with over 30 behavioral health leaders from across England and Europe in partnerships with the British National Health System. And through our British host, we were asked to join a number of global knowledge exchange partnerships with Australia, New Zealand, and other countries to share our collective learning. We met with leaders from the European Investment Bank, from Wellcome Trust, which is one of the largest philanthropic foundations in the world, and from Kokoro, which is, and each of these are major global philanthropic or investment entities, and each of them have platforms to focus on addressing behavioral health inequity. So they're very aligned with all the things that we do and that we talk about and that we care about. We met with leaders in neuroscience, innovation, public-private partnerships, and research on the impacts of improving behavioral health outcomes from Finland, Spain, Belgium, and the UK. And we met with leaders from the Institute of Health and Measurements and Evaluation, which was built with $1 billion investment from the Gates Foundation to bring data and analytics and evaluation to help shape healthcare decisions. We met with the Institute of Government Outcomes at Oxford. That was really interesting to hear how they do things differently, and doing a lot of the similar work that we're thinking about to support outcome-based decision-making in a range of public programs across the UK. And we met with local leaders and their nonprofit partners who are also pushing the edge on outcome-based contracting where providers are paid a unit rate for outcomes, and it's an interesting model that can shape how the Commission might invest in Mental Health Wellness Act funds for full-service partnerships. In fact, 2 days before the historic election for the Prime Minister, when we were over there, we met with a woman who was tasked with shaping their Labour Party behavioral health policy, and she was madly taking notes and learning a lot from a lot of the things that we shared. And we learned some things from her. And so we did all this in 3 days, working from morning to night. And so, so what's next out of all this? Because it was a lot of activity. With the permission from the chair, I'm working with staff to share these opportunities more broadly, and here's some of the possible opportunities. One is hosting a webinar with the British Institute for Government Outcomes to learn more about their models and how we can apply them to California. We have an opportunity to expand the capacity for impact-focused research in California that could be an opportunity for our university partnerships. Engaging in the UK to learn more about their people-based partnerships that leverage outcome-based funding to focus providers who develop tailored solutions to care that are driven by individual needs, which I think could be very powerful. And the model we saw very well that could be part of the FSP Lite opportunity that we've discussed many times here in California over the last 10 or 15 years. Another opportunity is visiting the Institute for Health Measurement and Evaluation, which is actually based in the University of Washington, although we were meeting with their London counterparts, and at the request of Bill Gates, which is working across with these issues globally. Or we could bring them here to share the work that we do, and would be key in informing the state's new mandate to improve our investment in prevention and early intervention, and the data systems needed to support that work, which are really fundamental. And these meetings have many new open opportunities. In the next 6 months, we've been invited to join ongoing work that can benefit from our lessons learned in California and can guide our opportunities. Today, the incoming Secretary General of the United Nations is leading a discussion around the Declaration of Brain Health, and Governor Newsom was invited to contribute a statement supporting their brain health strategies. In September, we have the United Nations General Assembly that will be meeting in New York, and the Commission has been asked to participate and host a panel on school-based mental health as part of a two-day UN science summit convening that will be led by the European Brain Council. In response to our London discussions, leaders working with the Clinton Global Initiative have reached out, and we just had a meeting with them a couple of days ago to explore the role of California in their September meeting. And again, they have global reach in convening lots of people who are like-minded around behavioral health. And they're very interested in California's commitment to school-based mental health innovation and opportunities for public-private partnerships. We've been invited back to London in October again to meet with the new British government that's been formed with the Labour Party following their election, and again with the focus on school mental health, digital health strategies, which they're doing a lot of good work in, and again, innovation in public-private partnerships. We're also in conversations with the Wellcome Trust about co-hosting a California convening with many of the organizations that I mentioned previously to facilitate this global knowledge and cooperation. And we're in conversations with the so-called OEDC, Organization for Economic Cooperation and Development, on participating in a panel at their upcoming global forum on well-being, which is a new upcoming topic, but really is getting a lot of attention and dovetails with our behavioral health interests that'll be in Rome in November, and would involve speakers with the European Investment Bank, the Mediterranean Economics Association, Kokoro, Wellcome Trust, and the Commission, all together on this broad strategy for public-private partnership focus on reducing disparities. So I want to recognize the work of the staff to support all of these opportunities, which has added more workload, but continues to grow our community engagement, strengthens our grant making, research, evaluation policy, and support for all these meetings. And as a public agency, the Commission's not really set up for this level of international travel, and the commissioners who have been invited to these events have agreed to pay out their own way or have raised money, partial support from non-public funds to make this happen. So there's been a sacrifice and a commitment from the individual commissioners recognizing the importance of this work. So it's a lot in the big picture. What I think it's about is really trying to grow the pie. There's a lot of money out there. It's not aligned. It's not connected. We don't have enough money today to solve our behavioral health problems individually, but collectively, I think it's possible. And so there's a lot of information, but I'm hoping Commissioner Brown and our Madam Chair might add anything else that I've missed to that long list. And thank you for this opportunity.
Thank you, Commissioner Carnevale. Commissioner Brown, I invite you to, please. And then any commissioner comments, questions, please, I invite all.
First of all, I want to thank Steve Carnevale for his tremendous work in organizing this delegation and this trip that we took. It was enlightening. It was a very productive and a very rewarding experience, and I think that was true both ways for us and for our British colleagues over there as well. We were very well received. They were excellent hosts. They, as you say, we had a packed schedule, and with the 8-hour time change, it got interesting at times. But we had some really productive meetings, and it became very apparent that there was a tremendous interest in what we're doing here in California, because in many ways it is very different than what they're doing. They have very dedicated and committed mental health professionals working there with long-term and in many cases significant programs, but they are far more siloed than we are. They don't have the same kind of collaborative efforts and cross-disciplinary engagement that we have here and are blessed to have. And so there was an interest in discussing that and in talking about that. And the other thing that struck me was the I think they're doing a better job in terms of the proactive Healthy Brain Initiative and support for that whole concept of the healthy brain. And it seemed that was not just the British delegation. We met with people that were from Scandinavia and from other countries that are very interested in it as well, and with financial professionals who want to see significant investment made in that endeavor. And that was very, very revealing and very, very interesting and very hopeful. One thing that just is maybe a little piece of business, if I could add this too. One of the things that we did, I took a fair number of copies of our report that we did, the criminal justice report, Together We Can, which focuses on collaboration and combined budgets and what have you, and handed them out. And I noticed as I was handing them out, we have pretty prominently featured on the cover of that we published this report in November of 2017. So it's getting a little bit dated in terms of not so much for the content, but for the published date that's on the cover. And it's time for us to maybe republish it. But I was thinking that, and discussing it with Toby, that perhaps it might be time for us to just freshen that up a little bit and have a little tweaking of the report. Many of the programs that are highlighted in that report were in their infancy when we started, and they've had a chance to work for a while, and I think we could probably do a little tune-up there, do a little freshen up in terms of the presentation on it, and then maybe republish it. But there did seem to be an interest in it, and I think that, coupled with our suicide prevention and the upcoming firearms report, I think would be a benefit, again, not only in California, but and across our nation, but across the world. And so I would just throw that out for some future thought, that we do something about a refresh on that particular report. But I was very proud to be part of the group. I can tell you that Commissioner Carnevale, Chair Madrigal-Weiss, and our executive director were extraordinary ambassadors for what we're doing here in California, and they were incredibly polished in their presentations and their discussions, and I think it's fair to say that we were very well received over there, and indeed they've asked us to come back. And so I think that it is a great opportunity, particularly with the fact that we have such a special relationship with the United Kingdom, and that we speak the same language. We're involved in many of the same things, and there's a lot of cultural similarities in many respects. And I think that there's a great opportunity for us here to see them as great partners, and we can help each other in this endeavor. So thank you.
Thank you, Commissioner Brown. I think, Toby, if we could look at the report and bring it up to date. And I would just like to add, I too think that there was a lot of learning, there was a lot of sharing. In one meeting, I brought up, I'm really proud of the reports that we've created and we have shared, and I have sent the PEI report, the suicide report. They shared data with us, much of the same data that we share in the PEI report. And it's not very dissimilar. And to be able to say, we have similar findings of what our communities, especially our communities of color. And I thought it very interesting. I know there's diversity in the UK. I know there's diversity in London, and yet the group representing the population does not at all reflect what is in the population, which, made note of that. I know when we talked about school mental health, you said the importance of student voice, which is not something that's necessarily, they haven't yet quite got there to the degree that we're advocating for it. We talked about doing things for an at versus with, and so other concepts that we brought up. And this was just really good dialogue around that. I think they were very pleased to see the collaboration. You have law enforcement, you have schools, you have business, and that was just, how do you guys do this together? And then we talked about the other commissioners and the roles that we play, and just how this is, we didn't get here overnight. So we talked about a lot of the history and how there's richness in the diversity. And so that was important. And we talked about this school to prison pipeline and how we're really wanting to break that up. And so that was a whole other concept. And I mean, there's just such rich learning conversations. And when we met with, I want to say bankers, but I know that's not right, but it's bigger than that. But just, you know, the brain health and brain economy and really bringing those conversations back into other venues, into our schools. When you are, you know, I always go back to the first UN meeting that we had. And I talk about Dr. Facundo, and this really does translate into the meetings that we had here in the UK. When they are explaining to countries that don't have other natural resources, and they're talking about brain health as the natural resource for communities that, you know, for example, in Argentina, this is what they talk about, the brain health, the brain economy, it's the richness of the people that is the natural resource. And so it behooves everybody to invest in the people and their brain health, because this is what's going to really change the world, unite it, and bring it in align with other countries. So there was so much learning. The communication continues to happen. We share resources. They continue to ask more questions, and we're learning from them. There's so much. How do you work with communities that are constantly seeking resources? How do we stay on top of it? How do we look at trends? So they have the trend data, and yet they're still having to figure out how do we quickly deploy to the trend data. So we're getting good at collecting the numbers. It's just how do we deploy the resources in a timely fashion. So I was very proud to be part of this group, and the fact that the work that this commission has done is starting to be able to inform and learn from other groups, not only here in our state, nationally, but internationally, is just an honor to really be able to lift this. So any other questions, comments from fellow commissioners, please? Please.
I just want to say I'm really encouraged by the work and your leadership that's happening. I'd like to, participate or have providers that are on the ground to add to this conversation, because I think that what you learned and what opportunities for school mental health, brain health, the opportunity to put a clinician that's on the ground, that's doing the work, to have these conversations and to connect the pieces, what I believe would add a lot of insight to the robust group that was put together. I think that, and then also I want to uplift in your work around the innovations is, as somebody that has participated as a small Black CBO in innovations over the last decade, I think it's important to have those public-private partnerships, and I really enjoyed the Berkeley visit, and I've been excited about the venture capitalists, connecting with the early innovators, and learning about just all around. I think the opportunity would be, once again, to bring CBOs into the mix. I believe that as someone that has been on the other side in the implementation and working with large corporations, and then being a CBO, and then working with counties, I think there's a lot of lessons that can be learned in the implementation. So I just think there's an opportunity in all the great work to, put providers that are smaller and bigger size and scope, so that they can learn from the conversation and really work on because the implementation and practice is opportunity for learning. So I'd say I'm excited for your work and to bring in CBOs, and then also change I don't know, I feel like there's a lot of learning opportunities for us, because corporations do it really well, the private sector, but I think nonprofits, small CBOs actually really do it extremely well, and we just don't scale, we don't have the business sense or opportunity. So I think there's a lot of lessons to be learned for the smaller providers, and how we can learn from the corporations. So really excited.
Thank you, Commissioner Chambers. Okay.
Just very briefly, just again want to acknowledge Commissioner Cannavale and his leadership. The trip to Berkeley was amazing, and to see the level of innovation, the cutting edge technology, and think about that being applied to behavioral health issues and to solve those issues is just amazing. I recall a time when mental health research was it always took kind of the back seat. And to think about this level of innovation and really cutting edge technologies being applied to solve behavioral health problems is just amazing. So I look forward to continuing the conversation, but just want to acknowledge your leadership in that.
Absolutely. Thank you, Commissioner Robinson and Steve. Thank you for your leadership on this. Okay, in other news, this month we have new staff to welcome to the commission, so I'd like to invite Melissa Martin-Mullard, Jigna Shaw, Norma Pate, Ryan Kopchak, and Toby up to the podium to introduce our newest staff members. The students.
Good morning, Commissioners and Chair. It's my pleasure to welcome Charles Lee to the Commission. Charles will be the Commission's Information Security Officer and part of the IT team. In this role, Charles will provide support to Commission staff and management and oversight of the Commission's Information Security Program. Charles is a cyber security expert, a 3D graphic engineer, and a systems architect. As Charles said, he's not just a pretty brain. He teaches fitness, dance, and practices taekwondo and kickboxing. And we're excited to have Charles on our team. If you'd like to stand, Charles, and welcome Charles.
Thank you. I'm not just here for work. I really believe in the work everyone is doing. I absolutely believe that half of the problems around the world would go away if everyone were both physically and mentally healthy. So power to us all. Thank you very much.
Thank you, Charles. Welcome.
Good morning, Chair, Vice Chair, and Commissioners. It's lovely to see you. I have the pleasure of introducing 3 new staff members this morning. So we have Katie. Come over here, Katie. Katie McKenzie is joining the Program Ops team to assist with reviewing plans and providing technical assistance to counties. She joins us after working for the Governor's Protective Detail at CHP for Governors Brown and Newsom for 10 years, and then the Department of State Hospitals in the Patient Management Unit. She worked there with counties to coordinate the statewide list according to nuanced patient need. So her experience in a fast-paced, high-pressure environment, as well as familiarity with the county processes, will serve her very well, and the commission, right? So thanks, Katie. Welcome. Good morning. Thank you, everyone. Kendall. Come on this side so you're not like let all the people see you. Okay. So Kendall Vargas is joining the Community Engagement and Grants team as an Associate Government Program Analyst. He will work on logistics planning as well as community engagement activities and then support the unit in various capacities. Kendall has experience with data collection, site visit planning, facilitation of meetings, hearings, and many other skills that will serve him well here. He has previously worked for Peloton, Franchise Tax Board, and Department of State Hospitals. He has developed a relationship-based approach to work that encourages collaboration and fosters teamwork. So we're very happy to have Kendall on the team.
Thank you.
Thanks, Kendall. Sarah, last one. Last but not least, Sarah Weber is also joining the Community Engagement and Grants team as an Associate Governmental Program Analyst and will work on community engagement as well as logistics and support as well. Sarah joins us after 4 years of being a middle school and high school teacher, right? So, where she implemented, right? Yeah, exactly. God bless her. Where she implemented social emotional learning curriculum in multiple schools and established gender and sexuality alliance clubs to support students and allies. So Sarah brings a wealth of knowledge to the commission relative to school-based behavioral health issues. So, yeah, thank you for welcoming them to the team.
Good morning, everyone. I have the honor of introducing Meredith Parrington. Meredith is our Summer Behavioral Health Fellow and is going to be supporting our student mental health efforts as well as our youth advocacy work. Please welcome me and please join me in welcoming Meredith.
Welcome, Meredith.
And we actually have two behavioral health summer fellows this year. And so this is Lila Gonzalez. She is from the Elk Grove area, went to high school here in Sacramento. She's currently pre-med, interested in neuroscience and psychiatry, studying at Williams College in Massachusetts. One of the directions that you have given us very clearly is to elevate the voice of youth. And so, we're really working to find all of these paths to do this. And both Lila and Meredith actually are helping us develop sort of a more formal process to recruit youth. And so part of their task for us this summer, and we have about 3 more weeks of their time, is to be critical in terms of how we're treating them and how we can design a fellowship that would be very youth-friendly and develop opportunities for them personally and professionally in ways that support them and support our ability to be better in the work that we're doing. And so they're both working to review some of our reports, and nothing like brilliant teens to tell you when your writing is not very clear. So, Lila.
I've never used a microphone before, but thank you for having me.
Welcome. All right, so welcome to everyone. We are so happy you're here. Thank you for coming. The Executive Director Performance Evaluation is scheduled to take place during the October Commission meeting during closed session. As part of that evaluation process, I am directing Sandra to conduct 3 anonymous surveys utilizing SurveyMonkey for a 360-degree evaluation. The 3 cohorts that will be surveyed are commissioners, commission full-time staff, and key external contacts. Sandra will de-identify, summarize, and share the results with me prior to presenting to the Commission in October. On July 18, 2024, the Commission, along with 5 additional state departments and agencies, was served a document request subpoena from Meta Facebook relating to the State of California versus Meta Facebook case over social media's harm to youth mental health. This is a routine subpoena. The Attorney General will be representing the Commission in this matter. This is a formal request to all commissioners to preserve all documents, including electronic communications relating to youth behavioral health. Sandra will work with Toby and the executive team to identify responsive documents, and Sandra will keep the Commission updated on the progress of the subpoena. Our final announcement of the morning is that May 23rd Commission meeting recording, is now available on our website. I want to welcome everyone again to today's meeting. The plan is to end around 3:30. Commissioners who are online, if you leave the teleconference meeting for any reason and decide to rejoin, please make sure to use the raise hand function so that the Commission staff can make you a co-host again. It is now time for Agenda Item 3, General Public Comment. This time is reserved for comments on the agenda that are not on the agenda. Wow, I am having a day. It's only my first cup. I'll get there. Okay, I want to note that for individuals providing public comment on Zoom, you will see a small timer in the upper right-hand corner of the screen. This timer will let you know how much time you have left for public comment. I also would like to note that we have an additional way that you can submit public comment to the Commission. Members of the public can email us at publiccomment@mhsoac.ca.gov. Comments submitted 72 hours prior to the Commission meeting will be shared with the Commissioners at the upcoming meeting. Comments submitted outside of that window will be shared at a future meeting. Public comments submitted to this email address will not receive a written response. If anyone interested in making a public comment regarding the announcements or other items, please make those during the general public comment time. If you have any technical questions, please contact Commission staff at 916-500-0577. At this time, I will ask Amariani to go over the public comment procedures.
Thank you, Chair. All members of the public will have the opportunity to offer comment as described in the agenda. If you would like to comment on an agenda item, please wait until that item starts. You may request to make public comment by clicking the raise hand icon on your computer or the app, or if calling in by phone, push star 9. You will be placed in a queue to comment on that item. When it is your turn to comment, the moderator will unmute your line and announce your name or the last 3 digits of your telephone number. When you are unmuted, we are able to hear you. We will do our best to take comments in the order they are received. Please note, once the public comment period for the agenda item starts, we will close the queue, so please make requests to comment now. The moderator will insert the word last comment next to the commenter's name or number to identify the last public comment. Members of the public should be prepared to complete their comments within 3 minutes or less, depending on time constraints. When we have reached the end of your time, our staff will let you know, but we will let you finish your thoughts. We don't mean to cut you off, but we do want to help everyone keep time. We truly appreciate your understanding with this process. Lastly, if there are any members of the public using translation technology, please notify the chair, and at least twice the amount of time will be given to you during the public comment period. A live meeting transcription or closed captioning is available for anyone participating in the meeting. If that option is not currently visible, please activate it located in the control bar at the top or bottom of your screen. So we do not have any comments in the room. Virtually, we have 3 virtual comments. First, we have Steve. Your line is open.
Hello, my name is Steve McNally. I'm from Orange County. I serve on a Behavioral Health Advisory Board, one of 59, with Welfare and Institution Codes 5604.2, which I ask you all to read. I'm speaking as an individual family member with schizophrenia. All his family relationships are restored, so I'm very appreciative of that. First, I want to thank you for what you do. And then I'm going to go back to something I think is very important, and that's silo breaking in California and connecting the dots. And one of the things is I think silos break when conversations happen. There's a lot of one-way discussion going on in California, but not a lot of two-way discussion. And a lot of that for me is transparency, access, and safety for people to speak publicly in meetings, even for people to feel safe enough to acknowledge what their relationships are by putting their names and their associations in the public view so you can see who's actually attending the meetings. And this is so difficult for me as an individual to see this happen. And I've had many positive comments I've seen you in public from some commissioners, but what I haven't seen is too much action to help line up the OAC to look upward and downward and to make sure that implementation of our aspirational programs in our state are smooth, effective, and known. And with the regulations of Prop 1 being developed, I'm a little bit nervous that the community's again going to be left at the door, wondering where the right door is and actually when it meets. Because while it's all transparent online, there's not a lot of promotion outside of eList of what's going on. And my fear is that a small group of people know a lot and a large group of people know very little. And those are your system users. And as Vivica will say, you know, I know one journey, my own journey, but when you have a system that doesn't document well, that journey, whether it's good or bad, defines the entire system. And so I implore you to, again, tighten up your relationships with the Behavioral Planning Council, the local boards, share your influence, maybe attend a local board meeting. Maybe I attend your meetings. Get geographically connected across the state and help us to bring the families back to the communities. Thank you very much, and I do love that timer. Thank you.
Thank you, Steve.
Next, we have Stacy. Your line is open.
Thank you. Good morning, Commissioner. Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. And I would like to support the comments of Steve McNally. I really enjoy his public comments, and mine actually overlap with his. At the last OAC meeting, I made public comment recommending to the commission that the commission form an innovations committee to advise and help with the commission's increased responsibility outlined in Proposition 1. REMCO would once again like to make the recommendation that a committee, not a subcommittee, be formed as soon as possible in order for the public stakeholders to give input into the parameters of the Innovations Partnership Fund. I realize that Deputy Director Kendra Zoller will be giving a presentation on Proposition 1 as a whole this afternoon. I took a look at her slides, and there is so much valuable and interesting information contained in them, and I really look forward to her presentation. However, I did not see anything regarding how stakeholder input would be collected yet. Although Prop 1 did not have the emphasis or specificity on behavioral health policies and programs being consumer, family, and community driven that was so explicit in Proposition 63, I do believe that this value is also a best practice. REMCO hopes that the Commission provides opportunities for robust stakeholder input on their administration of the Prop 1 components, not only on the Innovations Partnership, but on your other areas of responsibility as well. Please do not design policies and procedures internally or only with other government partners and then ask towards the very end or just before they are finalized, how do you like this draft? I learned a lot from Rusty Seelix when the government partners began to do this after Proposition 63 was passed. He got really upset and called them out on this. I am not upset yet, but I am getting anxious because I know that meetings are being held between government entities, but there has been very little involvement towards getting public stakeholder comments. REMCO will give it a little more time, but we are hoping that the OAC will show the leadership as you are known for and begin collaboration with and inclusion of the community stakeholders as soon as possible. Thank you very much.
Thank you, Stacy.
And our last public comment is Laurel. Your line is open.
Good morning. Okay, well, there's a lot going on in the world and in the country. I'm Laurel Ben Hamida. I am with Muslim American Society Social Services Foundation in Sacramento and with some statewide activities. And I want first to say that Stacy's comments are important and I back them up. I think it's an ongoing problem. I'll take, for example, the headlines today about Governor Newsom's giving permission to clear homeless encampments. Let's just call that maybe a political move, given the atmosphere in the country. But it seems to me that given the issues and anxieties on the ground about this kind of move, that the commission needs to have a voice, take a voice to make sure that whatever is done is humane and is not ignore the fact that we just don't have the housing in California that's affordable. Care Court is rolling out and it's not fully rolled out yet. That's another issue to be concerned about. On the positive, I'm so happy to hear that you took a trip to Europe. I think it's a wonderful beginning. I don't know how it was funded, but I'm glad it was funded because it seems to me that a couple of years ago, state employees anyway couldn't travel overseas. So you're going to learn a lot from this. And I think before you take a trip like that, you might contact an organization like Muslim American Society Social Services Foundation. For example, one of our former board members has a brother who previously was the executive director of a Somali community-based mental health association in England. And you could have had a site visit there. I don't know how much on the ground site visits you had on the front lines. And her cousin was an employee and may still be a mental health clinician with the National Health Service. So organizations that have immigrants and refugees can help you make contact. But of course, the first priority is making the contact on the ground here. Thank you very much.
Thank you, Laurel.
And then we will be taking one more comment from Rachel. Your line is open.
Hello, thank you very much for all of your work and all that you do. I am the CEO of California On Track. We are an early intervention psychosis program practicing a comprehensive coordinated specialty care program in Los Angeles and in Los Angeles County in association with UCLA, although we are a private business. We were awarded recently a $2 million grant in the round 5 mental health grants of the California Children and Youth Behavioral Health Institute, which grants were awarded and chosen by the California Department of Healthcare Services and the California Mental Health Services Oversight and Accountability Commission, so yourselves. Those grants, those requests for grants were submitted in November 2023. Award decisions were supposed to be made in December of 2023, but awardees were notified in March of 2024. Total grants to 99 awardees were named, and of those 99 awardees, only 12 of us are CSC programs. And that round 5 grant was in order to fund CSC programs. So in March, we received notice that we were one of those 12 awardees for $2 million. Since that time, we have not received a subaward agreement, notice of funding, or any movement at all. What this means to all providers is that we are unable to initiate our programs and help the people in need in our state who are so badly in need of this. And the point of this grant was for early intervention. Every week and every month that this money is delayed, these programs wait to start. We have been fortunate enough to operate an adult coordinated specialty care program, and we have essentially robbed Peter to pay Paul to start a pilot program for our teens. But I do not believe that has been the case for any other CSC provider in the state. I implore you to look at the grants that were awarded in the round 5 California Children and Youth Behavioral Health Institute mental health grants, which were awarded by the MHSOAC and DHCS. And I implore you to make it a priority that those awards are in fact granted to the 12 CSC providers in the entire state of California. Our services are in dire need, and I was thrilled to see that later in the day there will be an agenda item about a strategic plan. But I implore you—
Thank you, Rachel. Your time is up. Please wrap up your comment.
Before you focused on the future, I would implore you to fund those grants that were already awarded. Thank you for your time and all of your work.
Rachel, thank you for that. We are absolutely committed to ensuring access. I will have staff inquire about that. Thank you for your comment. We are now going to move on to agenda item 4, consider approval for the minutes of the May 23rd, 2024 meeting. At this time, I would like to invite commissioners to offer comments or ask questions. Seeing none, I would ask for members of the public to request to make comments regarding agenda item 4 by clicking the raise hand button on your computer or the app, or if calling in by phone by pushing *9. Are there any public comments, Mariani? Please raise your hand now as the queue will be closing.
I do not see any public comment for this item.
Okay, so before I entertain a motion, I ask that all commissioners, both online or in person, unmute their lines. I would entertain a motion that the commission approves the May 23rd commission meeting minutes.
So moved.
Commissioner Robinson, do I have a second?
Second.
Commissioner Brown and Carnevale. We have a second. And a third. I saw Brown because I'm looking at Brown, so we're going to go with. And there are no comments, so we are good to take the roll call.
We'll take the roll now. Requesting folks that are online to unmute their lines. Bontrager,
Abstain.
Brown,
Aye.
Bunch, Carnevale,
Aye.
Carrillo, Chambers,
Aye.
Cortese, Danovich,
Aye.
Gordon, Mitchell, Robinson,
Aye.
Roulette, Vice Chair Alvarez,
Aye.
Chair Madrigal Weiss.
Aye.
Motion passes.
Thank you, Sandra. Agenda item 5 is the consent calendar. This month's consent calendar includes the approval of one innovation proposal from Sierra County and a resolution authorizing the State of California Workers' Compensation Insurance for commission volunteers. First, the innovation proposal is to allow Sierra County to join the Electronic Health Records Multi-County Collaborative for up to $910,000 in MHSA innovation funds. As you remember, in May, Commissioner Roulette brought forward the recommendation that any innovation proposal brought forward to be considered on consent contain information on how the proposal aligns with BHSA priorities, sustainability under the new BHSA funding areas, and consideration of the impact of the BHSA to existing programs. Sierra's proposal outlines BHSA alignment and sustainability. Commission staff has sent the documents related to this project to all commissioners, and a copy of the staff analysis for the proposal has been provided in your packet. Second, our Chief Counsel, Sandra Gallardo, has clarified that under state law, for the Commission to ensure our workers' compensation policy covers commissioners as well as other persons who volunteer with the Commission, such as committee members, we need to adopt a formal resolution to that effect. Sandra, please share some of the details of the resolution with us.
As a result of the passage of Proposition 1, on January 1st, 2025, the number of commissioners is expected to grow by close to 70% to 27 commissioners. Currently, the state of California workers' comp insurance does not cover commissioners or any unpaid volunteers to the commission, such as commission committee members. With the increased risk presented by the additional 11 commissioners, I recommend that the commission pass a resolution that would allow unpaid volunteers to the commission to qualify for the state of California workers' compensation insurance for any injury sustained during the performance of their duties. And as a note, California Labor Code 3363.5A specifically requires a public agency or commission such as ourselves to declare by adoption of a formal resolution to have the state of California workers' compensation apply to its volunteers, to its unpaid volunteers. I've explored with Human Resources, and the increase in cost of this is estimated to be minimal, if any. So I entertain questions, and if not, I do recommend that the resolution that has been included in your meeting packet is adopted by the Commission.
Commissioners, are there any questions? I see none in the room, and I see none online. Thank you, Sandra. Commissioners, you have in front of you the language for the resolution, which has been included in your packets. As a reminder, any commissioner can remove an item from the consent calendar. That item would then be considered as a regularly scheduled agenda item at a future commission meeting. At this time, I would like to invite commissioners to offer comments or ask questions. Saw none here in the room and none online. So now at this time, members of the public may request to make a public comment on Agenda Item 5 by clicking the Raise Hand button on your computer or the app, or if calling in by phone, press star 9. Once the public comment period for this agenda item starts, we will close the public comment queue. So please make your request to comment now. Also, please limit your comment to 3 minutes or less. Are there any public comments? Please raise your hand now as the queue will be closing. Please open the line for public comment on Agenda Item 5 and start with comments in the room on Mariani.
We currently do not have any comments in the room or online.
Thank you. Then I would, at this time, entertain a motion that the Commission approve the consent calendar that includes 2 items. First, funding for Sierra County to join the semi-statewide enterprise health record multi-county collaborative innovation project. And second, the Commission adopt the resolution authorizing workers' compensation insurance coverage for persons providing voluntary services to the Commission without compensation within the meaning of Labor Code 3363.5 and California Government Code 3111.
So moved.
Thank you, Commissioner Gordon. We have a motion. Do I have a second?
Second.
Thank you, Commissioner Carnevale. We have a first and a second. Sandra, if you could please take the vote.
Sir. Bontrager.
Aye.
Brown.
Aye.
Bunch. Carnevale.
Aye.
Carrillo. Chambers.
Aye.
Cortese. Danovich.
Aye.
Gordon.
Aye.
Mitchell. Robinson.
Aye.
Roulette. Vice Chair Alvarez. Chair Madrigal-Weiss.
Aye.
Motion passes.
Thank you. Moving on to Agenda Item 6, we will hear an update on the state budget and commission expenditures. I would like to invite Deputy Director Norma Pate to present.
Thank you, Chair and Commissioners, for your time today. Let's see here if I can figure out how to, there we go, okay. Governor Newsom and state leaders agreed on the 2024 California budget in June. A large number of harmful cuts to critical programs were rejected by the June budget package. Several essential state programs were protected by utilizing reserves and delaying program expansions. The budget also borrows heavily from future budgets, commits a larger portion of future revenue growth to schools, and only temporarily increases revenues. If revenue conditions do not improve, the state may be unable to sustain core programs and stall much-needed investments. The June budget package highlights key components, and it examines how it protects and enhances services that aim to improve the well-being of Californians with low incomes, Californians of color, women, immigrants, and other historically excluded. Across the 3-year budget window, which is fiscal year 22-23 through 24-25, the state closed roughly $47 billion shortfall. Budget solutions for 2024 include $16 billion in spending reductions, $13.6 billion from additional revenue, $6 billion in funding shifts, nearly $6 billion in withdrawals from the rainy day fund, $3.1 billion in funding delays for food assistance for undocumented Californians is being delayed for 2 years, as well as a wage increase for people who provide disability services for 6 months, and $2 billion in deferrals. 1 month of state employee payroll costs will be shifted from June 2025, the last month of 2024-25 fiscal year, to July 2025, the first month of the 25-26 fiscal year. Revenue solutions. Budget solutions include temporary increase in the state revenues, which helps to avoid more harmful service cuts, but will also reduce revenues in the future. Under state operations, reduce state operations spending by $3 billion starting in 2024-25. Basic government activities are supported by this funding. In collaboration with state departments, the Department of Finance will implement 2 measures to save money: reducing state operations spending tied to vacant positions for general fund savings of $762 million in 2024. As part of the governor's state budget for 2025, the governor must propose permanent elimination of vacant positions, cutting state operations spending by up to an additional 7.9% for general fund savings of approximately $2.2 billion in 2024. Savings will be achieved through operational efficiencies and other cost reduction measures on top of the cut to vacant positions. These reductions would equal roughly 10% of the total general fund state operations spending. Impact on critical programs and services. The budget agreement rejects many harmful cuts to critical programs. One notable program cut is to health program. Sorry, I lost track of my, oops, sorry. Okay. Trying to go back. Okay, sorry. The budget agreement preserves an expansion of Medi-Cal eligibility for undocumented adults ages 26 to 49, as well as in-home supportive services for undocumented Californians. The in-home supportive services was proposed to be eliminated for all undocumented Californians in May, which would have resulted in more poverty for many immigrant families. So we're thrilled to see that this stayed in the budget and it will continue to be funded. I think I have this backwards, I'm sorry. Okay, sorry, what happens next? Budget decisions are made all year round, not just during the month of January. As part of the 2024 budget package, the governor and the legislative leaders will pass additional trailer bills in August and possibly amend the 2024 Budget Act. For the commission's budget, each year, the commission is presented with a budget update in July and at the beginning of the new fiscal year, and again in January, which coincides with the presentation on the governor's proposed budget for the following fiscal year. Staff also provide a budget presentation in May that coincides with the governor's May revision. The goal of these presentations is to support fiscal transparency and ensure that the commission expenditures are in line with the commission's priorities. This year's budget is significantly less than prior year budgets because we received one-time funds that are spent over multiple years. Funding for our current initiatives have not been reduced, and we are continuing to implement our programs with prior year funds. For our operations budget, the Budget Act of 2024 includes 3 positions to support Proposition 1 changes to the Commission. The 3 newly created positions are necessary to accommodate the additional workload associated with the implementation of Proposition 1. As we begin to implement the new requirements in Prop 1, we will work closely with the administration and request additional resources for the requirements that will be implemented in future years. Personnel makes up about 20% of the commission's budget. For our operations, our core operations include funding for rent, office supplies, training for staff, stipends, conference fees, travel for commissioners, committee members, and staff, and other operational costs. Currently, our operations budget is about 10% of the commission's budget. And as I mentioned earlier, the governor's budget includes language to reduce state operations spending by up to 7.9%. At this time, we have not been notified of any reductions to our operations budget, but I expect to receive notification from the Department of Finance later this year, and I will keep you updated on any reductions for our budget. Commission priorities, we estimate this year we'll need approximately $60,000 for communications and a little over $1 million for our research and evaluation efforts. For our budget-directed items, our FSP program, our budget-directed item includes $400,000 ongoing funds for the evaluation of FSP outcomes. We currently have contracts with Third Sector and Healthy Brains Initiative. We will come back to you later in the year for a proposal for this year's $400,000. Then Prop 1, to facilitate the name change from the Mental Health Services Oversight and Accountability Commission to the Behavioral Health Services Oversight and Accountability Commission. $100,000 is being provided for the next 3 years to help support that effort. Local assistance is approximately 70% of the Commission's budget. And these funds are allocated through grants or contracts to counties, cities, and other organizations that provide services in the community. The Mental Health Wellness Act grant program provides $20 million each year to improve community response to people facing mental health crisis. The Commission authorized grants to expand the number of empath crisis stabilization units near hospital emergency rooms, expand mobile support services for older adults experiencing depression and other serious mental illnesses, and conduct a substance use disorder pilot to increase access to medication-assisted treatment. The Commission has identified children ages 0 to 5 and maternal mental health as a focus of Mental Health Wellness Act program funding. Staff will present a recommendation to the Commission later this year on this project. The Student Mental Health Services Act aims to enhance mental health care services in public schools. The Commission has allocated over $300 million in funding for public schools across California to collaborate with local mental health professionals. The goal is to establish on-site mental health services for students, providing crucial support within educational settings. There is a total of $25 million available, and multiple grants will be awarded this year. Applications were due July 28th, and staff are currently scoring the applications, and awards will be announced in the coming months. $7.6 million from fiscal year 2024 will be allocated for this grant cycle. And then for community advocacy through MHSA funding, the Commission awards $6.7 million in contracts to local and state level organizations to provide advocacy, training, education, and outreach on behalf of 8 specific populations. These contracts support statewide and local community-led events which highlight mental health services for underserved populations and provide opportunities to reduce stigma and inform state and local leaders about the needs of underserved populations. This year's procurements, throughout this year, we'll be allocating additional funding for Mental Health Student Services Act, which is being scored now, and the Mental Health Wellness Act for maternal mental health and 0 to 5. Also, Mental Health Student Services Act statewide technical assistance coordinator, K through 12 advocacy, and immigrants and refugees advocacy. So you'll be seeing these proposals later in the year. Today I need expenditure authority if you'll consider awarding funds to Public Work Alliance to design a strategy for building a financial sustainability network model for the Alcove sites. Alcove Youth Drop-In Centers are one of the Commission's grant programs. A one-time grant of $15 million was provided by the Commission, and additional grants will be implemented through the CYBHI. Alcove Youth Drop-In Centers are designed to provide youth and their families with innovative and comprehensive and youth-friendly mental health services. The financial sustainability of Alcove remains a challenge, and the contractor will help the Commission explore Alcove financial sustainability challenges and opportunities. In addition, $150,000 for Stanford for our research and evaluation consultant. We're looking to bring on a psychiatrist to help with the Alcove program and other programs that the Commission is implementing. And that is all I have for today, and the motion is that the Commission approves the fiscal year 2024 expenditure plan and associated contracts, and happy to answer any questions that you have regarding the budget before you vote.
At this time, I would like to invite commissioners to offer any comments or questions. Thank you for your presentation, Norma. You answered everything. There doesn't seem to be any, very thorough.
I'll ask a question.
Please, Vice Chair Alvarez.
Great, thank you. And thank you, Norma. I will also extend my appreciation for the overview. One thing that I appreciate in the presentation is the acknowledgement of the changes with implementation of the Behavioral Health Services Act and the potential shifts in roles and responsibilities, not potential, the shifts in roles and responsibilities of the commission. And I'm curious, so much of implementation of the Behavioral Health Services Act is unknown, right? There's not a roadmap that lays out exactly how things will unfold and the implications of those changes. And I'm curious if there is an opportunity in our budget or where there may be opportunity for like this wiggle room that would allow us to pivot for more stakeholder engagement or pivot for stronger partnership opportunities. Like I'm just so curious about that, just because there are so many unknowns, and beyond the Behavioral Health Services Act, there's just a lot of unknowns, period. And I'm curious, like where there is that, I don't know a better term, wiggle room for those types of unexpected things that are coming down the pike. And I'm sure many of us who run nonprofits who are doing this work are thinking the same thing. So I would like to hear a little bit from the commission's perspective how that works.
Thank you, Vice Chair Alvarez. So our budget, so there is wiggle room. There's wiggle room in a number of ways. The implementation of Prop 1 happens over time, and so we do have the opportunity to engage the governor's team and the legislature through the budget process to adjust our allocation as implementation happens over time. So there's that sort of strategy to release pressure on our existing budget as when the legislation to put Prop 1 on the ballot was being discussed, we had detailed conversations with the finance staff on both the legislative side and the executive branch side and highlighted the uncertainty that you're talking about. And so the door remains open in discussions with them as we work to figure out how the commission can best support implementation, both in terms of the explicit functions that we have, as well as the more expansive opportunities that fall under the commission's broader authority to advise and guide the governor and the legislature. Operationally, as Norma pointed out in terms of our budget and how the funds are distributed between the outgoing dollars for local assistance, the core operational funds like our personnel costs, and then the operational funds, we do have wiggle room, to use your term. We do have some discretion in terms of the categories. And we are required to spend these dollars consistent with the rationale with which the commission received them. So funds for the Mental Health Student Services Act, for example, must be used within the Mental Health Services Act. Funds within the Mental Health Wellness Act must be used within that category, and so forth. But there is a percentage of discretion within those dollars that allow us to move them around to address unanticipated or emerging opportunities. That is always done in consultation with the Department of Finance and with our accounting staff. And so I would say the commission has that authority, and if there's an area where members are interested in a deeper dive in understanding either where we're spending dollars or if we can increase resources in one area like community engagement, we'd be happy to explore how to do that. Unfortunately, we don't have some of that information at the moment because, as Norma points out, we're still waiting for direction from our fiscal departments over the kinds of reductions we may need to take on our operational side. Does that answer the question?
It does. Thanks. I appreciate that.
Commissioner Chambers, please.
I just want to uplift your comments, Vice Chair. As we've been reconvening the committees, there's been a lot of movement and folks ready to, roll up their sleeves and have some intentional work relative to the implementation of Prop 1. And the theme that has consistently come up, and you uplifted as an example, is the community engagement piece and finding outside of the box ways to engage folks that we typically don't engage, whether it be going place-based, going to, going to the jails or going somewhere else, really to really get that feedback. So I really appreciate, Toby, the flexibility and consultation with finance, particularly around having wiggle room to do certain things as things emerge, because I know our committees really want to make sure that the community stakeholder and feedback, and that we're able to document that and send that to the legislator and the governor, the voice of the community. So thank you for that guidance.
Thank you, Commissioner Chambers. Please, Commissioner Robinson.
Just high level, the decision to work with Public Works Alliance and with that contract, how did that come about? What's the process for that?
I haven't really been involved in that. Go ahead.
So the commission has made investments over the last maybe 6 years to stand up the Youth Alcove Drop-In Center, and we engage all of our local partners who are involved in that effort. Some of those are funded directly by the commission through a competitive grant process. Some of those are funded with county dollars. We facilitate a learning collaborative where each of the local partners, and that includes some emerging partners here in Sacramento County, to talk with them about the challenges they're facing in establishing these centers, but also the challenges they're facing in a long-term sustainability model, looking at workforce, looking at infrastructure, IT, even public understanding. And at the core of that is the question of fiscal sustainability. That is, as you may understand, Commissioner Robinson, often at the top of the list, because if we can't finance them in a sustainable manner, then the staffing and these other challenges just won't happen either. So we asked them, so our partners identified this challenge. We asked them who they would like to work with, because in essence what we're doing is funding consulting on behalf of these partners, and we want those partners to identify the experts who they feel can best meet their need. And so that's how that came about.
Other questions, comments? I see none in the room and no other online. So at this time, members of the public may request to make a public comment on agenda item 6 by clicking the raise hand button on your computer or the app, or if calling in by phone, pushing *9. Mariani, are there any public comments? Please raise your hand now as the queue will be closing.
We do not have any comments in the room or online.
Thank you. So I would entertain a motion that the commission approves the fiscal year 2024-2025 expenditure plan and associated contracts.
So moved.
Vice Chair? Thank you, Vice Chair Alvarez. I have a motion. Do I have a second?
I'll second.
Thank you, Commissioner Carnevale. Sandra, we have a motion and a second. If we could take roll, please.
Great. Bontrager.
Aye.
Brown. Aye. Bunch. Carnevale.
Aye.
Carrillo. Chambers. Chen. Cortese. Danovich.
Aye.
Gordon.
Aye.
Mitchell. Robinson.
Aye.
Roulette.
Yes.
Vice Chair Alvarez.
Aye.
Chair Mariel Weiss.
Aye.
Motion passes.
Thank you. For agenda item 7, we will discuss transformational change in behavioral health with a panel on transparency and accountability standards within mental health. With this agenda item, we hope to explore current opportunities, goals, and the use of data to reduce disparities and close gaps in equity. I'd like to invite Dr. Melissa Martin-Mullard, Chief of Research and Evaluation, to begin our conversation and introduce our panel members.
Good morning. I have the privilege of introducing our panel today on transformational change in behavioral health, transparency, and accountability. The panelists will speak from subject matter expertise and community experience to outline opportunities for strengthening our accountability systems for behavioral health. Before I introduce the panelists, allow me to share brief background and context for this agenda item. As you know, the Commission identified data as a priority during the January 2023 Strategic Plan report out. Since then, staff have continued to shape a research and accountability agenda that supports our initiatives and portfolio and has included activities such as community engagement, data analytics, conversations with experts in metrics and evaluation frameworks, and landscape analyses of data availability. With the passage of Prop 1, we have additional opportunities to support the governor's bold agenda to transform the behavioral health system and improve outcomes for individuals, families, and communities in California. With tremendous investments and ambitious reforms in behavioral health over the last several years, what is needed now is an overarching accountability framework that supports these aims. This framework should focus on resources, services, and outcomes. What are our investments? What are we purchasing? And what outcomes are we achieving? We can make better, smarter decisions about how we use our limited resources when we track and monitor what services and supports our systems of care are providing and what outcomes those services are achieving. With that, let me first thank our panelists for joining us today to offer their perspective. LaShawn Francis, Stephanie Welch, Dr. Ryan Quist, Dr. Sergio Aguilar-Gaxiola, and Deborah Odo-Kent. Our first panelist is joining us online and is LaShawn Francis, Senior Director of Behavioral Health at Children Now. She will share work that Children Now has done on accountability for the children's system of care. LaShawn, thank you for kicking off the panel presentation.
Thanks so much, Melissa, and thank you to everyone and the commissioners for having me today. I'm really thrilled to be here. Melissa, I don't know if we're able to share slides or if I should just free flow it, which I'm perfectly happy to do.
We'll get the slides up. Just give us 1 sec.
Yeah, I have the slides up in the room if you want to just say next slide when it's time to.
Perfect. Okay. And I'm really sorry that I wasn't able to join you all today in person, but hopefully we're still able to have a robust conversation. So my name is LaShawn Francis, and I'm the Senior Director for Children Now. Next slide. And for those of you who don't know, we are a statewide research policy and advocacy group that focuses on the whole child And we also lead something called the Children's Movement with a unique network of more than 4,600 diverse organizations. Next slide. So one of the things that we did a few years ago, and admittedly, this report that we did is a few years old, but I think the outcomes of the report are actually still quite relevant, and probably even more so with the passage of Proposition 1. So one of the things that we set out to do was to really identify what is currently out there in the world of children's mental health and substance use from various state agencies, right? And we wanted to know, essentially, what are we being required to report? What are our systems being required to report? And what do they tell us about how kids are doing? Our goal was to understand what the gaps were and then to make recommendations that would promote better outcomes for young people. Next slide. So here's what we did. We looked at a slew of information from a variety of places. You'll recognize every one of the logos on this slide. And what we realized very quickly was that there was a ton of information out there regarding youth mental health and substance use disorder. So we narrowed it down to the previous 3 years. So you'll notice that some things are missing in terms of data metrics. For example, there is data on mental health and SUD in the maternal infant health assessment data sets from CDPH. However, at the time we were doing this report, the most recent data was from 2015, which was outside of our scope of the past 3 years. We really wanted to focus on information that was kind of newer and relevant. So I imagine that if I were doing this report again today, we'd be able to update some of these data metrics and really have a better understanding about where things are. Next slide. So here's what we found. We found about 80 metrics that were publicly reported on from those agencies that I mentioned. And then we narrowed down what domain they were in. Were they population indicators? Were they system performance indicators? And within that group, what type of indicator was it? So what you'll notice very quickly is where we had the least amount of measures and where we had the most amount of measures. So we had the least amount of measures in quality and outcomes, right? And so, quality, very, very simply, we're saying the degree to which health services for individuals and populations really increase the likelihood of whatever the desired health outcome is, right? And for outcomes, we were really thinking about the impact of the healthcare service or intervention on the health status of that individual, of that child, of that young person. And you'll see that most of our measures that we publicly report on are about systems use and early identification. So things we want to know, but really shows kind of where we're lacking in having an understanding of how kids are doing in the state of California. Next slide. So here's what we found, and I don't think it's shocking to anyone at all. I do think that one of the things that kept coming up for us was there were significant gaps in disaggregated demographic data. So age, and I know that we're talking about young people, and what we usually do is we just say either under 21 or under 26, but really we were thinking about, what is the difference between infants and toddlers versus school-age children versus transition-age youth, and can we disaggregate demographic data by age in that way? Same thing, race, ethnicity, sexual orientation, gender identity, geography, also significant gaps. So some places were reporting on these things and some places were not. The other thing that we found was there was just a lack of data of non-clinical settings. So what's happening at home, what's happening in communities, what's happening at schools? As you all know, we find that young people present differently in different settings, and that can signal a mental health need or a substance abuse need, right? So we wanted to know every area that kids were interacting with, what the data said about how they were doing. And then, of course, there was just no consistent data across delivery systems. So, for example, we couldn't really find a bunch of information on what was happening on the private commercial insurance side versus Medi-Cal. So, obviously we're reporting more on Medi-Cal, but it would be really good to know what commercial insurance was covering as well. Next slide. So you'll see a full list of this. We kind of comb through each source. So Department of Healthcare Services, CDE, even the OAC, Department of Social Services. We comb through to figure out what type of data was available and then what were the limitations in that data. And it was actually pretty consistent, right? I only have 2 examples up here. But for DHCS, you kind of had a lot of information on common diagnoses, health plan quality measures, timely access measures, but really were lacking in quality and outcomes data, inconsistencies across race and ethnicity and geographic strata. So, some opportunities here, right? So, we know some things, but what don't we know is a pretty long list, unfortunately. And the same thing with DSS. And if you go to the report, you'll see also CDE and OAC and what that looks like. Next slide. So here are statewide opportunities for better data. We've talked about this in the past, Cradle to Career, CalAIM, CYBHI, but today we're talking about Proposition 1. This is a new opportunity. I also wanted to flag transitional kindergarten because now we have a quote unquote new population to focus on as we roll that out through the state, and we'll be able to have hopefully better data for what the needs of the school age children who aren't in kindergarten and up or K through 12 are. So really looking forward to not just the opportunity that Prop 1 presents, but also the opportunity that some of these new programs present. Next slide. So here's where we kind of did a deep dive into what we think the state should really focus on when they are thinking about what data to collect, right? So demographic data speaks for itself. I think everyone really understands what that means, but just in case, we realize that there's just a lot of opportunities to better disaggregate data. So for example, we have a category in our demographic collection called Asian American that we haven't really disaggregated into its constituent groups, right? And so it can mask important and significant disparities within the context of behavioral health. And so this really means that the state is not able to understand how different ethnic groups experience systems and services, and they might even make false assumptions that access is realized under the larger Asian American umbrella, when in fact it might only be realized for some people, some communities, and not others. The other thing that we focused on was disaggregated data for special populations. So young children, when I say young children, I mean that 0 to 5 population, children and youth in child welfare, foster care, and JJ involvement, right? Because what ends up happening is we need to have a better understanding of what their unique needs are, given the fact that many of them are actually involved in multiple systems. So here you'll see a need not just for the direct reporting out in each system, but better cross-sector collaboration, data sharing as well, since one youth might actually touch on a number of different systems. And then we are collecting data on trauma, and it's interesting because it's an opportunity to better understand what our population needs and align investments to those needs might be based off of what we're collecting around ACEs, right? So for example, the current questionnaire for children asks about exposure to community violence. A population-based state policy approach to that question could guide resources to certain communities to not only help children heal from trauma, but also to implement new programming that could prevent and address community violence. We're also thinking about gathering consumer experience and satisfaction. Before this panel, I heard a lot of commissioners talk about community engagement opportunities under Prop 1, and I can't stress how important that is, particularly as we figure out whether or not young people and their parents are actually satisfied with the experiences they're having with the health, school, or whatever system that they're in, right? And so this is really where we get the opportunity to center the voices of youth and families to understand how the behavioral health system needs to be redesigned to meet their specific needs, right? So our landscape scan revealed that there's essentially very little to no data on consumer experiences regarding navigating the systems that's reported publicly. So we really want to take a look at that and understand that the experiences of children and families is essential to identifying system changes that result in just better use and access of behavioral health services. And then, of course, the big one is focus on outcomes and quality. And so for outcomes, this one's really interesting because we tend not to focus on outcomes. We tend not to focus on it at all. I think there's an opportunity that we can under Prop 1. But really what we were calling for is a plan that identifies target metrics to move forward, such as we want to dramatically reduce suicide attempts among LGBTQ plus youth, right? That is specific. That is not, that is not such a broad-based statement. You really kind of know which population to serve, which population you're thinking of when you implement suicide prevention policies or programs. So by focusing on outcomes specific to key demographics like race, ethnicity, SOGI, et cetera, we can really ensure that its investments improve the lives of those kids who are historically underserved. And then finally, focus on quality. We can think about quality on both a macro and micro level as something that will require large systemic change. We can also think about it on a micro level in terms of positive interactions with children, youth, and families. And so we really can improve quality by focusing on measures that reflect positive behavioral health across sectors and institute greater transparency and accountability of the overall child serving system. So really thinking about what needs to happen where individuals or adults who work with children are collecting uniform data, regularly following up with children and families after services are delivered, and connecting families to services and supports that the families value, right? That's how you can focus on quality. So we go into that at length in our report. Next slide. And what we decided to do really was to suggest some new metrics that could be collected. Obviously, this list is not exhaustive. Next slide. But it is something that we heard repeatedly from people, and I put in kind of where that would fit. So, for example, what % of kids 0 to 5 are receiving support for identified developmental or behavioral health challenges, right? That's an access question. That's not something that we collect right now. Consumer experiences. We heard a lot about really wanting to explore how folks are experiencing the system. So what % of kids want a mental health services, but they can't get any? What % of young people were satisfied with the provider that they did see? Things like that, right? We also looked into the cross-sectionality of systems and how mental health crops up, for example, in the school system. So towards the end, you'll see number of missed school days due to a mental health issue. These are things that I think we can collect that so that we can really understand not just what the impact is, but who are the young people who might be at risk so that we can better serve them and to give them the services that they need. So that is my presentation. I know that we're kind of doing questions at the end, but really happy that I can share the work that we've done, especially as the commission explores Prop 1 and its impact and where we can go from here. And next slide just has my contact information if anyone has any questions. So thank you.
Thank you so much, LaShawn. Next, we'll hear from Stephanie Welch, Deputy Secretary of Behavioral Health for California's Health and Human Services Agency. Stephanie will share updates on agency's efforts to translate the accountability mandates outlined in Prop 1.
Good morning. Nice to be back. I feel like it's cooler than last time I was here. I feel like I've been here presenting in July for the last couple of years. So thank you, LaShawn. I was taking copious notes, and that's really kind of the main message that I wanted to share today is that we are really in the information gathering mode. And so for me, I'm going to give a high-level presentation, but really came today so that I could listen, hear what some of your questions are, and take them back to our departments. Thought it would be good to ground our conversation today, if we could go to the next slide, in just a reminder of some of the things that we're trying to accomplish when we think about accountability and outcomes. And I appreciate that LaShawn's presentation before me was really focusing on, did this make an impact in the areas where people wanted an impact to be made? Did this make a difference in people's lives? I think also when we design what we're trying to, answer questions towards, we really should be focusing on the things that we're trying to accomplish with Prop 1. And so, again, just lifting up that the focus of some of the changes that are in Prop 1, which we're really kind of trying to rebrand as overarching behavioral health transformation. You guys have heard me talk about this before, but it really is a mosaic of a variety of behavioral health initiatives that goes into putting together all the puzzle pieces to make that mosaic so that Prop 1 is possible. So this can't be thought of, and the data conversation can't really be examined outside of what we're doing with transforming Medi-Cal in particular, but also the work that we're doing in some of our other departments, including advancing and working towards parity, and trying to reduce health disparities. So first and foremost, Prop 1 does focus on the most vulnerable and at risk, and has specific set-asides for children and youth. And so I think, part of what we need to look at and ask ourselves in does Prop 1 in particular, and I'm sorry, does the BHSA in particular have an impact on those populations that are targeted? It also broadens the population to include individuals with substance use disorder. So how are we going to be inclusive of that when we advance the work we want to do around data and metrics? It really has a focus on including housing as part of the overall delivery of health care. How does that fit into our schema of what we want to understand? How does having stable housing improve health outcomes and behavioral health outcomes in particular? One area of excitement, and I'm hoping that's why my good old friend Sergio is here, is to advance the use of community-defined practices as a key strategy to reduce health disparities. And then also, I think there is and warrants some discussion about how to measure the impact of changes to the community planning process. Is that process leading to improved outcomes for people? And then, of course, to increase transparency and accountability. So those are some of our goals, and so we have to make sure that we're going to be measuring them. Next slide. So just wanted to lift up again and be really clear here today, coming from an agency's perspective, I highlighted our responsibility with all of you, which is to collaborate to promote transformational change through research, evaluation, and tracking outcomes. Little daunting, big statement there, but we have a responsibility, and in partnership with all of our departments and other governmental entities, to have our eye on that prize. That is the goal of which we should be focusing on. There are other important pieces of information on there that are relevant to this conversation. As we will talk about, our department, the Department of Healthcare Services, is working very diligently on a variety of different things. One of them is grasping how to collect the data from an IT perspective, I guess. But again, there are many areas that the commission themselves needs to be consulting with DHCS on. And one of those is determining statewide behavioral health goals and outcome measures. And I think I failed to put it in this slide deck, but there will be and is a required process of which there will be an external stakeholder process to develop statewide metrics and data. And so I believe that work is going to be kicking off this fall. And I wish I knew I'm assuming it's September. And then also we at agency have many departments. As you know, we have 12 and 5 offices. And so there also are significant roles for the OAC to play with consulting with our Department of Public Health on population-based prevention innovations and our Department of Healthcare Access and Information, which leads all of our workforce strategies. And so those are also areas where, of course, we need to be measuring our progress and impact. Next slide. So these are just the big buckets of what is legislative required around quality measurements and disparities. So as I mentioned, establish a behavioral health performance and quality metrics in consultation with stakeholders. So I will make sure that in fact, when I stop talking and presenting, I will send a text so I can figure out when that is. But I do believe that I think we're looking to start that work in September. Also, obviously, to measure and evaluate the quality and efficacy of behavioral health services across California. And I think that's important because I think it really speaks to what LaShawn was saying, that people want to know. People don't want to just know how many services that someone got or what kind of diagnoses we have here in the state, but they want to know that people's lives got better from the services that they received. And then another really important part is to identify demographics and geographic disparities so that we can do what I mentioned before, what are the pillars of Prop 1, which is to reduce disparities and to double down on that. Next slide. So I think I will not do justice to maybe how some other people have presented this, but I think, the vehicle to get at a lot of this data is going to be how we utilize the county integrated plan, as well as what will come next. And I'll talk about the transparency report next. But there's a lot of new information that will be part of the county integrated plan. First, we've talked about this before, but it's a more global look at all the different funding sources that go into public behavioral health. So you've got obviously the BHSA funds, but there's opioid settlement funds, there's SAMHSA funds, PATH funds, realignment funding, the federal financial participation that is part of our Medi-Cal program, et cetera. Also the budget, there will be a budget attached to the integrated plan that will be all of the planned expenditures. Obviously, there are still revenues. We never really talk about the prudent reserve anymore these days, but that still exists, and adjustments that counties are making throughout the process. And these expenditures, and I think that's really important, need to align with statewide goals as well as the local goals. And our statewide goals, since I'm sitting next to my local partner, need to align with local goals in a broad, being a more broad umbrella, of course, to create local flexibility. But again, I think we all need to be rowing in the same direction. Also, even though the state will be responsible for leading workforce efforts in terms of that 3% that goes towards that, counties will still have to document in their integrated plans how they're going to support a workforce that reflects being able to meet the needs of the plan that they're putting forward. So do they have the people to execute the plan that they're submitting? Next slide. I think these are other things that I'm honestly, as a lifelong, more on the mental health side, policy person, learning about myself, but there are other tools and resources that give us a broader picture about the overall behavioral health of a community. So plans must be developed with consideration of the population needs assessments of each Medi-Cal managed care plan and in collaboration with local health jurisdictions on community health improvement plans. Some of this work is underway. I think Toby and I have had a couple discussions about being able to maybe bring some of this information forward. This work was actually underway prior as part of improvements to our Medi-Cal program prior to the Prop 1 being imagined, I guess. But really interesting, and I think it's really important, especially for the commitment that this particular body has towards prevention and early intervention, to utilize that information when these local decisions are being made and seeing the role in partnership with our population health partners at Public Health. It must be informed by local stakeholder input, and I think that speaks volumes in terms of what do you all want to know, and what information do you need at your disposal locally in order to make informed decisions about how you want to spend your money. And then performance outcomes will be developed by DHCS, as I mentioned before, in consultation with you all and various stakeholders. Next slide. So this is what I refer to as kind of like the report card on how it's going with the integrated plan, the County Behavioral Health Outcomes Accountability and Transparency Report. We have dubbed it the BODER. I'm struggling to adopt that acronym, but I just call it the report card. Counties are required to report annually on the expenditures of the funding sources I just mentioned. So all of those funding sources, how are they being used? Do they have unspent dollars? And really the goal is to look at service utilization data and outcomes, but also through a health equity lens and including workforce metrics and other information. So a significant amount of work, body of work that needs to be done there. And then something that is new is that DHCS, and this is not new, this exists in other elements of our system, but it is new for the BHSA, is that DHCS does have the authority to impose corrective action plans if counties are failing to meet certain requirements associated with this annual transparency report. Next slide. So again, as I mentioned and want to lift up the importance of this, is that plans are required, that the plans, the 3-year plans, and then the annual reports that are the report card on how the plan is being implemented, shall include data through the lens of health equity, identify racial, ethnic, age, gender, and other demographic disparities. Data and information may include, this is a may, I like to always highlight shall and mays so that we can follow what we are trying to implement. But other data that we really want to encourage to be considered and used is data around, who is utilizing the services amongst the eligible population. Like I mentioned before, we do have a tighter target population, and we've got to make sure that target population is being served. And I just looked at the sheriff, so one of those target populations are people who are coming home from incarceration. We want to look at things like who is incarcerated, who's experiencing homelessness, who is using the housing that interventions that are being supplied, and what types of children and youth, just to speak specifically to LaShawn's comment, are utilizing and being touched by the work being done. So metrics shall identify demographics and geographic disparities and have to report on quality and efficacy of services and programs. And next slide. I also really wanted to lift up and not forget that we do have basically about a 10-year process of which we are part of a pretty robust state audit report. And I haven't put a ton of critical thinking into this, but I see it as an opportunity to really have another layer of accountability on us as state implementers, and making sure that we are really achieving the things that I just outlined. We said that we were going to focus on accountability and outcomes, and I do think that this state audit report and process should hold us to that. Next slide. So these last 2 slides were provided as an update, like a sneak peek from some of the work that DHCS is doing. I can tell you I am not an IT expert or a data expert, and so I am not going to be able to speak to a lot of detail of these slides. But I think that what I did want to share is that we really are moving to a web-based platform. So these integrated plans, and Ryan, you can correct me if I'm wrong, these integrated plans will actually be quote unquote uploaded into a web-based system. And the goal here, is, this is really important to us, is we have to get rid of the bad, the stuff that's not useful, and focus on the good and make it easy and accessible for people to use and to get real-time data and access from. So our team at DHCS will be managing this platform. And this way, when there are secondary guidance or policy changes or quality improvement that needs to be made, that's something that we can do quickly and internally. And And we think that this is going to give us more of an ability to shift more quickly. I, like other people sitting up here, went through the first time we did this, and I think it took us probably a decade, and someone can quote me on that, to get all of the guidance out by the time we got to like the innovation work. And so I think our hope, going to the next slide, is really to, and you can't really see it on there, I apologize, but at the very bottom, what is my left-hand corner, it shows us evolving from a skateboard to a hot rod, rather than starting with one wheel and just getting to a car. And I think the intent of this graphic is that our goal in approaching this responsibility this time around, rather than 20 years ago, is to be innovative along the way, not just put pieces onto the vehicle. We don't want to just fly the airplane while we build it. We want to evolve from, a very elementary process to a very sophisticated process. And this is where I think you all can be helpful to us in terms of learning how to become more innovative. So this area is something we're just starting to think about, but the idea is, how do we do better to understand technology, to understand tools at our disposal, and take an opportunity to utilize those things? I think some of the primary values behind this would be, we don't want people to collect and report information that we don't use. We want outcomes to be reflective of what clients and consumers and family members want to experience. And we want to be able to change things more quickly. I've come here several times, and I am looking at you, Commissioner Carnevale. And we are challenged as large bureaucracies to make changes quickly, and to be responsive to data. We have a couple of different efforts in some of the other areas of the work that we do, about trying to reduce these very significant time between what we know and implementing it into practice. And so I think there are some hopes that we will be able to do this better, and we're just having some initial thinking about that, and we look forward to you all joining us in doing that work. So with that, I'm done with my presentation. I think the last slide is just simply just a reminder, just for your public audience, to please make sure that you're following those 3 websites, and make sure that you get looped into DHCS's stakeholder listening sessions. We have one coming up on Tuesday that'll be focused on SUD integration. So please make sure you're tracking those websites. Thank you.
Thank you, Stephanie. Next, we'll hear from Dr. Ryan Quist, Behavioral Health Director of Sacramento County. Thank you, Dr. Quist, for offering a county perspective on accountability.
Yeah, thank you for having me. Ryan Quist, Behavioral Health Director for Sacramento County, and I'm also the president of the County Behavioral Health Directors Association. And I did have a couple prompts that they asked me to make sure that I hit on, so I'll let you know what those were as we go. But first off, I was asked to talk about the county's perspectives on the importance of data and accountability for system level decision making. So to start off, I'd say, there's a saying that says, we measure what matters. And I think we could all have different perspectives on whether or not what we're currently measuring is what matters, or is that something that we can continue to improve upon. The BHSA effort presents a unique opportunity to update and improve upon the public transparency of our county behavioral health resources. The county level, we consider ourselves stewards of the public dollar, and very much want to ensure that our community partners and stakeholders have the information they need to better understand what we do and how we do it. Most importantly, our county behavioral health directors have for some time embraced the idea of being held accountable for the outcomes that we produce. In fact, OAC's own analysis of FSP data has shown that our existing full-service partnerships significantly reduce justice involvement among enrolled clients. And this study was done using existing FSP and justice data and proved what we already knew to be true, that our services change lives. In addition, data can be a powerful tool in helping to identify disparities and making meaningful progress on closing those gaps. This is why the ability to disaggregate data by race, ethnicity, sexual orientation, gender identity, among other factors where data is available, is so important. I can't underscore that enough. That's the type of information that we need in order to make sure that we're making progress on disparities. Today, the state collects significant amounts of data from consumers, from providers, from plans, from system-level data related to county behavioral health. Just for example, we report data such as, we're health plans. So just like any other managed care plan, we are being held to requirements as it relates to reporting on our health data. And so we're being held accountable for things like network adequacy, timely access, quality standards that are put out by the feds and by DHCS. And then for MHSA funds that we administer, we report on both the funding as well as programs and even specialized data reporting systems, which I think we've all come to be familiar with, as well as recognize its own quirks, the DCR system. Our biggest challenge today is that those data that are collected in a way that the data are collected in a way that do not allow for aggregated data to paint a statewide picture. Counties and our providers have faithfully reported on our funding and programs in the ways requested and required, but the information we send to the state is not always requested in a way that supports 21st century data-driven system transparency and accountability, or in a way that supports taking action to respond in real time, making system improvements. So we are very excited about the ideas that we're contemplating with DHCS around a new framework or technology foundation to sort of update how we're able to both collect and report on data. Since joining Sacramento County, it has been one of my goals to make what we do and how much more, I've aimed to make what we do and how much we do more accessible to my communities so that they have a better understanding of our programs, services, and obligations as county behavioral health. And this is not an easy feat. We're both a managed care plan as well as a community. We're also talking to community. And so we end up with all of these different acronyms and unique language that we have to speak to be a managed care plan or to be part of a county system. And that's not always understandable to our community partners. And ensuring that we're communicating, and it's important that we ensure that what we're communicating and what matters to my communities is the utmost important to me and my department. So we're working very hard to have a dialogue with community around what their values and importances are, to make sure that that's what we're addressing, both with the work we do as well as what we're reporting back to them. One other thing I comment on is we are a managed care plan, but we're also unique in that we're embedded within the county structure. And that is such a strength because we're sitting at the same tables with child welfare. Managed care plans are making great strides in that efforts, but we've been there. We've been sitting at the table with our child welfare partners, with probation, with our justice partners, the courts, public defenders, district attorneys, our schools. We're sitting at the table within our local communities, asking to be held accountable for the work that we do, and constantly having those conversations about how can we do better, how can we be a better partner. Another topic I was asked to talk a little bit about were challenges presented by our current legacy data collection systems. So one example of a legacy data collection system that needs to be updated, undeniably, is the FSP data collection and reporting, or DCR data collection system. Currently, DCR data is a requirement for our full service partnership programs. And the quality or lack thereof of the metrics, so far this data has little practical use. Maybe it's about how the data is challenging to get access to. Maybe it's about how we collect the data. I don't know. But we need to revisit that and really have some thoughtful conversations about it. It's an important, I actually say it's an important cautionary tale that sometimes more is simply not more. I'm sorry, that more is simply more and not better. So we want to make sure that we're not just adding on more requirements on top of this already rather complex scaffold of data reporting requirements. So how do we inform that? The National Quality Forum, the nation's leading organization for establishing and validating health quality measures, outlines several key requirements for quality measures. Among these, data have to be reliable, valid, feasible, useful for accountability and performance improvement. They need to be evidence-based at minimum. New measures undergo extensive academic review and scrutiny to ensure that, especially when measures are used for accountability, that they have met the high bar set by the National Quality Forum. We need to be really thoughtful about this. We're going to be held accountable by them for them. We need to make sure that they are actually measuring what we intend them to measure. For example, supporting clinical decision-making is even more challenging, as often data needs to be both reliable and fairly close to real time to support clinical decision. This is not a problem that is unique to county behavioral health. Healthcare data overall struggles with data lags and validity, but it's something we're going to need to address and focus on. One solution counties have adopted with support from OAC approved innovation funding is the development of a semi-statewide electronic health record, which Sacramento County is a part of. And with this CalMesa EHR, it's called SmartCare, counties are aiming to have better data that can be shared across counties and support more real-time clinical decision-making and support system performance management. Counties are only 1 year into the rollout, and we know there's a lot more work to do on that. I'll look at Al and recognize the challenges as we're implementing, but it's already showing promising results. And then I think the last area I just wanted to talk about is around the need for standardization of metrics and outcomes. Standardization is vital so we can aggregate, disaggregate, and understand impact at the local and state levels. That is so important. We're going to need to be able to look at it at the state level to be able to understand and tell our story at the state level. I think that's something that we are struggling with our current data. We also need to ensure that we develop metrics that build upon our existing data collection requirements and systems where the data is good, such as our claims data. We send a lot of claims data. That's something that I feel like we could mine more. We could find out what our existing data telling, what story our existing data telling. We also reconsider where data collection is not serving our clients or the public with improved quality and outcomes, and then ensure that any measures that are aimed at accountability are actionable, meaning that as counties with the resources we have the power to move the needle on those indicators with the funding and services we have. The concept of accountability for actionable measures is not controversial and is a core principle of health data measurement, generally speaking, as I described earlier, also a core value of our behavioral health systems. Key in our efforts will be to ensure that as we build this new system for accountability and outcomes, that what we're measuring matters to our communities and policymakers, that we do not place new burdensome data collection requirements on counties and, importantly, our contract providers, and that data is collected by the state in a way that supports valid, actionable, and meaningful measures aligned with the state and local priorities. I do want to highlight that you've heard a lot about it. You can't miss this message. We are still in a behavioral health workforce crisis. We need to recognize that as we're working on developing data collection, more data collection, we're keeping in mind that the more time that our clinicians are spending working on data collection, that's time they're not spending with consumers. I still have a 30% vacancy rate among my county staff. That is dramatic, and that is, we need to make sure that the very valuable and scarce time that is available for serving consumers is being sent, actually impacting consumers' lives. I will also underscore some of the points that Stephanie made in her comments. I think it is fundamentally important as OAC is thinking about developing and providing recommendations around accountability measures and similar initiatives, that there is a very deep study of what is already being collected. I think consulting with DHCS, understanding all of the initiatives. There are new, you think that maybe you think BHSA is the main big thing that's coming. There are so many big things that are happening right now in behavioral health. And a lot of them also are hitting on similar topics. We have new quality metrics that we're reporting in meeting CMS requirements. We have a new EQRO that's coming around to be monitoring our performance as a health plan. We need to make sure that as we're developing the new data that we need to collect around BHSA, that we're putting it in the context of the whole system. What is the whole picture that is currently impacting behavioral health in the county perspectives, or else we're just going to add that one more thing on top of everything else. And I think that that collectively, if we have a unifying vision of that overall perspective, we'll really be able to get to the goals of being responsive to what it is that our communities would like to know and what we need to be reporting in order to hold ourselves accountable. And thank you.
Thank you, Dr. Quist. Finally, we have a joint presentation from Dr. Sergio Aguilar Gaxiola, Founding Director of the Center for Reducing Disparities at UC Davis, and Deborah Odo Kent, Founder and Executive Director of the Health Education Council. They will present on the importance of community voice and positioning equity at the center of efforts around accountability.
Well, thank you, Melissa, and thank you for the kind invitation to share some thoughts with you, the commissioners. And thank you. And I'm delighted and honored, actually, to have my colleague and my friend and colleague, Debbie Oro-Kent, with me. We have been collaborating for over 15 years now. And she has an incredible experience working with communities that she will be sharing with you some of it. I want to bring to your attention that I'm going to be focusing on, when it comes to transformational change in behavioral health, on the critical importance of listening and building trust and creating trustworthiness, especially listening. And you have, Stephanie, and you, Ryan, have spoke about the critical importance of having being informed by the local stakeholders, and to listen to people, to what matters directly to consumers and their families. So that's of critical importance. But George Santayana, this philosopher, Spaniard, said something that really has resonated for me for decades, and that is, those who cannot remember the past are condemned to repeat it. So I decided to include this picture that goes back 20 years, Stephanie. It is another summer for you and I. That was in the summer of 2004. This happened at the Fresno State campus. Daryl Steinberg, I don't have to explain to you, a champion for behavioral health, not only statewide, but nationwide, was rallying. I organized this rally over there. And it was, I continue to be very passionate about it, because I have seen firsthand the inequities in access to care for those who most need mental health services, behavioral health services. And I being responsive to George Santayana's wisdom, I want to just very briefly share with you some of the things that were happening when Prop 63 passed and it became law, became the Mental Health Services Act in January of 2005, almost 20 years. And I unearthed a presentation I gave in 2005, in which I have a few things that I want to share with you. One is a letter that Steve Mayberg, you may remember, the Department of Mental Health leader, sent to stakeholders. And it says, I'm quoting, to expend funds made available through this initiative to transform the current mental health system in California, this will not be business as usual. Eventually, access will be easier, services more effective, and out-of-home and institutional care will be reduced. Boy, here we are, 20 years later, And then at that time, the Department of Mental Health proposed intent, and listen to this, was to build a long-term vision of transformation of the current mental health system, and also initiate phased-in multiple plan components, which will eventually become integrated. Community services and supports, prevention, early intervention, innovations, etc. Okay? And one last thing that I want to share from that era is that the vision, the stated vision of the Mental Health Services Act at that time was to reduce long-term adverse impact of untreated mental illness, including something that you mentioned earlier today, Mara, Commissioner Madrigal-Weiss, including reduction of stigma and discrimination, expand access, and this has been resonating for me for decades, expand access to unserved and underserved populations, expand access to successful service program, focus on effective services and cost-effective expenditures, including prevention and early intervention, which is an incredible thing that is happening in California and is not happening anywhere else in the U.S. The investment that California has done in prevention and early intervention. That's why I'm not surprised that when you go, the commissioners, the three commissioners, Brown, Carnavale, and Madrigal-Weiss, to London, they are going to pay attention because it's remarkable what is happening as part of the Mental Health Services Act. So I just wanted to share that with you. But let me go back. Let me go to my to the slides again, and that is if transforming the behavioral health system of care is the goal, then listening and building trust and creating trustworthiness with those we intend to serve must be front and center. I know that you would like to use may or shall. I would say should be front and center. And one thing that I want to tell you also, and this another word of wisdom, is that the most basic of human needs is the need to understand and be understood. The best way to understand people is to listen to them. And this is from Ralph Nichols. And so the bottom line in all of this is that I have no question that all of us here are totally invested in enhancing the mental health of our communities through improving care and reducing mental health disparities. But if we are going to listen attentively, actively, and incorporate what we listen for those things that, the things that matter to people, then one critical ingredient is meaningful community engagement. And I'm emphasizing meaningful because not all community engagement is meaningful. You can do harm. Actually, I have seen many examples of doing harm by engaging some communities. Debbie can tell us a lot about that as well. So the one thing that I want to share with you, what I mean, I'm delighted that Stephanie and Ryan and you, the commission, have spoken about the importance of focusing on the hardly reached populations, the vulnerable, the historically underserved populations. Well, this is 30 years ago, okay? I conducted this study in Fresno County. This was county-wide. We focus on, people of Mexican origin. And we got funded from the National Institute of Mental Health. It took us 5 years to do this study. And of those that we included in this study, the Mexican, American, and Prevalent Services Survey, who were needing services because they met criteria for one or more mental disorders. And those who received services, 1 out of 3 of the US born, 1 out of 6 of the immigrants, and less than 1 in 10 of the farm workers. Okay? Would you say that has changed? No. Actually, I believe that is worse. There are some indicators that are worse. And these are the kind of things that we need to keep in mind, that we don't repeat the mistakes that we had made. That there is a lot at stake about that. This is going to give you a little bit of insight because we took the care of looking at what were the barriers: institutional, structural, perceptual, which is a stigma, but to share with you institutional barriers. And this, by the way, we did a follow-up just with the severely and persistently mentally ill in our study. And so this data focuses on that particular group, almost 300 people that we follow up with. Over 50% wouldn't know where to go for services. I mean, so simple. 50% I have no pay. 1 out of 4, there are no treatment centers near my home. 1 out of 5, I can go to the clinic during open hours. And, 1 out of 5, I can go as frequently as needed. I wish to have more time to discuss this more in depth with you, because would you say those barriers are gone? They are not, and this is what is at stake, I think, Stephanie, with this new opportunity that we have to get it right. So what is your North Star in transforming behavioral health? And this is a question to the commissioners, question to you, Stacy, and question to all of us. Well, let me share something. This is outcomes that matter. What is the road ahead? And what we have here is, matter to whom? Because sometimes we really lose sight of what are the outcomes that we're focusing on. And we don't ask, we don't listen about what matters to those who ultimately will benefit from this. The other one is who defines the outcomes? Another one is who benefits? Another one is wrong turn. There are gonna be wrong turns as well here. How do we know when we get there? But one thing that I want to share with you, and this is just to let you know that our commitment with the Center for Reducing Health Disparities that I founded and direct is very simple, is to serve the underserved communities. And so I'll share a little bit based on that experience. And something that we have over and over experienced is this idea that if you build it, will they come? Well, by now, I can share with you that people won't come, because it depends on who builds it and how they are perceived by the ultimate beneficiaries, how it is built, if we go and listen to them or not, and where it is built. Because we, continue to look, unfortunately, sometimes not where the needs are, where it is convenient to systems, and there are, I continue to work very closely with farm workers. My God, they continue to have, to be way underutilizing services. And it is about time that we think, is there another way that we can go to where they are at, as opposed to being the waiting mode? Like, come to us. Here we are, whenever you feel the need to do it, as opposed to the seeking mode, which is we go to where you are at, and provide services, mental health services. That is in existence now. So one thing that I want to mention that Debbie and I are very much involved with, this is work with the National Academy of Medicine. We have been working for over 5 years. I was honored to be asked to be the co-chair of this work and it is on assessing meaningful community engagement in health and healthcare. And the first resource that that the National Academy of Medicine released is this conceptual framework that you see here. But what I want to connect the dots for you is, and it is front and center in our discussion here, is the centrality of community engagement, guided by several principles, including trust and trustworthiness, and also, how that is connected to transforming systems of care through advancing health and mental health equity. We know. I hope that you are curious enough to take a look at this at a later time. But that is not the only thing that we have, that the National Academy of Medicine has released. There are other goodies that have been released. One of them is these 7 impact stories. And one of them that I want to bring to your attention is the Walkability Project. There are 3 impact stories that the National Academy of Medicine released, 3 in California, okay? And one of them was done with Debbie Oroken. And Melissa, I don't know if we can play it. It is 4 minutes, so bear with us, okay? But this is about listening actively, and do something about the listening. There is no audio.
The Sacramento region in Northern California. This was a $60,000 planning grant from RWJ as part of the Invest Health initiative that was supposed to last a year, I think. Our proposal focused around food security. We submitted the application for the city of Roseville, and our work in that city was really in the lowest income neighborhoods. The California Department of Health Services data showed that that neighborhood was a food desert. And food was really the issue. I mean, it was a documented food desert. When our team got together, we wanted to re-vet the data. Like, we wanted to validate, is food and food security the highest need? And so when we got funded, we formed a 5-member multi-sector team that was going to really embark on this work. The first thing we did is lay the intention out that community engagement and hearing voices of folks not traditionally involved around the table was fundamental to our project. We just talked to people, and we kept hearing, for example, the name Lupita. Well, we wanted to meet Lupita, and Lupita ended up hosting a backyard barbecue. It turned into a larger event in her backyard. We went to after-school programs and met with parents as they were walking to pick up their kids. We really cast a very wide net. We wanted to just start with a new slate. Like, we obviously talked about food, but we just said, like, what's nearest and dearest? Like, when you think about health, what do you think about? What comes to mind? And food was not the highest priority. What came up was safety, connection, walkability. And so basically we pivoted and changed our approach. What consistently came up was the neighborhood park. The park was not safe, homelessness, drug use, drug paraphernalia, lighting, treescaping. And that is causing lack of utilization of the park. The one thing that was food related is many of the moms said there's grocery stores that are close enough for us to walk and we like walking. But what we really need is safer routes to walk. We need a couple of sidewalks where they're not. We need on and off ramps where we could push our stroller or navigate our cart a little bit easier. A lot of the solutions that residents came up with were pretty low hanging fruit. You know, we started with treescaping. The city found some community development block grant money, immediately improved the sidewalks, so there was increased walkability. Parks and Rec started implementing programs. Kaiser Permanente gave us 2 park improvement grants. We built a classroom on the park, an outdoor learning center. One of our partners with the city said, you know, there's this effort to reduce greenhouse gases. And part of that is retrofitting current lighting of city streets and local parks to LED lighting. That's funding that's coming down, and that's maybe an opportunity. The magic that kind of happened was they were the first park to get their lighting improved. The only other amenity was a very, very, 100-year-old pool, but it was old and needed repair. The priority for that was elevated because the community was saying, this is a valued asset in our community. It is worthy of being prioritized for investment. And so the renovation happened. It recently reopened. They're having a celebration. There was some very, very visible changes. So is our work still involved with food and food security? Yes, it is. It's just broader. Quality of life and well-being, like all of these issues are highly, highly interconnected. It is the responsibility of the research and academic community to think differently, to engage differently, to ask differently, to listen differently. It's not enough to do the traditional, we posted a flyer and nobody came. It is talking to that one person and saying, you live in this neighborhood. What do you think is the best way to listen to other folks? Would you be willing to talk to us? Like, we have to hold ourselves and others accountable for what does engagement really mean. This is a new day for engagement. And if we don't begin to embrace it and operationalize differently, we're going to continue to see the same kind of outcomes.
Okay. Talking about listening and pivoting, based on what is heard. There are many lessons related to community engagement, meaningful community engagement here. The other resource that I want to share with you, and there has been discussion as to how do we measure? We cannot change what we don't measure, okay? So one of the things, another goodie that the National Academy of Medicine released last year, a little over a year ago, was 28 measures of meaningful community engagement. Let me go back. And this was based on 2 years of a very comprehensive review about the measures available internationally, not only in the US and Canada, but internationally about how to measure the progress done on doing meaningful community engagement. So there are 28 measures available. One beauty that I really am very proud of that is that each of the measures is mapped into the conceptual framework. Okay, so we know exactly which part of the conceptual framework is being tapped by that particular measure. So an invitation once again for you to look into that. One thing that I want to mention to you is that with money from you, from the Mental Health Services Act, through the innovation component, we did for years this model, the international collaboration and transformation model in Solano County. We provided, evidence that it is possible to transform a whole system of care, working with people directly and what matters to people. And one of the things that happened with funding from you also is that we created a learning collaborative, and we trained over 160 representatives of counties the ethnic services managers, the MHSA coordinators, etc., participated. And we did it for a full year. 3 of the 11 sessions that we provided, in monthly sessions were focused on community engagement because that was the most important piece for Solano County itself. And building trust and becoming trustworthy organization really emerged from this experience. So I have 2 more slides and I'm going to be done. People ask me often, well, you have been doing community engagement, meaningful community engagement. What are your main lessons learned? So I'm simplifying this in 4 S's, One is to be sincere, to be simple, to be straightforward, and to shut up and listen. Okay? So my last slide, it is what are recommendations for you? I mean, for the California HHS and for an organization like the Mental Health Services, the Oversight and Accountability Commission, and other organizations, to the counties as well. One that I want to mention is that Cal HHS Behavioral Health should, and I use should there, co-create an organization-wide meaningful community engagement framework that effectively engages all Californians, and in particular, historically underserved communities, and has trust and trustworthiness embedded throughout strategic planning, implementation, evaluation, and dissemination. And there are 3 other considerations that I finally want to share with you before we go to Debbie. Support Cal HHS in co-designing a cultural and linguistically appropriate community engagement framework to effectively engage and serve diverse and underserved communities. Also provide training to Cal HHS using relevant and culturally responsive resources and strategies that translate into meaningful community engagement plans. And finally, provide technical assistance and training with a focus on listening to communities attentively and actively, and on building trust and becoming trustworthy. Well, thank you so much for listening. Debbie?
Yes, thank you for the opportunity to share my boots on the ground, community-based perspective around data, and I so appreciate your prioritizing use of data to close the gaps around equity, around setting a very broad stakeholder table and prioritizing community engagement. Thank you also, Sergi, for taking us back 20 years. I do think, many of the priorities you listed were similar, and I do think we're in a different time for building programs that address equity, that all along the way, whether we're on that skateboard or the scooter or the car that's eventually developed, that embeds on an ongoing basis the voices of community, the solutions generated and lifted up by community. And before I go on, I'm going to say, Stephanie and Sergio, you have not changed a bit in 20 years. Mr. Mayor, maybe not. Just kidding. So I'm going to jump to slide number 3. So I'm with the Health Education Council. It's an organization I started 33 years ago, specifically to address the health disparities that existed in the Sacramento Valley region and surrounding counties amongst diverse, low-income, underserved, immigrant communities in our region. In our work, and even 33 years ago, we knew that the majority of health is determined by what happens outside of that doctor's office, what happens outside of that clinician's office, where people live, work, play, pray, shop, learn, and grow old. It is in communities and homes and neighborhoods, places of work, faith schools, grocery stores, gathering places with family, friends, and others where health really happens.
We know these as the social determinants of health, the underlying factors like healthy food, housing, education, all the non-medical factors that influence health outcomes, like the conditions that people in which they are born, grow, work, live, and age. All of these social determinants of health are impacted by the vital conditions of thriving communities. The Center for Disease Control identifies those vital conditions as basic needs for health and safety, like food, fresh air, safe neighborhoods, our natural world, whether or not we have clean air access, exposure to extreme climate changes, heat, flooding, etc. Housing, meaningful work and wealth, lifelong learning from infancy into adult and throughout life, reliable transportation, and what they call perhaps the most foundational and important vital condition for living healthy, thriving lives, belonging, a sense of belonging, and the opportunities to build civic muscle. It is in these contexts that the Health Education Council focuses on 5 petals, if you will work, and its intersection to health in communities and their outcome. Access to resources and services, social connection and mental health, economic well-being, community safety, and wellness education. The 2 most foundational approaches of our work are partnership and collaboration. And given the complexity of the issues we face today, we know that no one sector can fundamentally improve the health outcomes of communities in our neighborhoods and in our state. And the second is robust, authentic resident engagement, engaging, listening to, meeting people where they're at, those with lived experience, with living experience. We believe that people who are closest to issues affecting their communities are also closest to solutions. This slide, I think, sort of gives the steps of what was outlined in the video that Sergio shared. You know, often we are a grant-funded organization. We apply for funding. We use databases to tell our story, to document need. So we do a lot of digging into existing data. We always take that data because it is somewhat removed. It's aggregate data, it's population-based data. And we take that back to residents to say, is this what's important to you? How do you feel about this, this piece of information, this data that's being covered in your neighborhood? And sometimes we hear things like, duh, we already know that, right? And we try to further understand what does that mean in the context of individual families or homes or neighborhoods. We often, after we hear what we hear from residents, change our direction. And in the example of the video, it really wasn't food, even though every database was showing that food was an issue, that was pointing to trying to move towards a full-service grocery store. The community hospital needs assessments were pointing to higher rates of obesity, chronic disease-related issues related to obesity, related to food. What we heard from residents was very different. I think it's our responsibility to pivot and to change direction and to use what we are hearing from the data to find solutions, to look at opportunities, to look at what's already out there. Often our work does not take extra money. It takes talking to different people to see what are the opportunities out there to align with what people are asking for. We believe we build trust through action. You ask people what they think, you ask people what their opinion is, they want to be listened to, and they want to see action based on that input. We always turn around and listen again. Next slide. So this book is the story of, it's kind of an extension of the video you saw. That work was very much focused on Weber Park. And part of, I think, what I've learned is that Our work focuses on real-world data, if you will, and I know that's an academic term where real-world data is what we can gather from medical records or medical charts or individual records. In our world, real-world data is about listening. It is about holding focus groups, key informant interviews with folks who have been historically excluded from the discussion. We focus on the qualitative data and align that with other data. And so this book, A Park for Everyone, is the story of that data. It is the story of what we learned and heard from the eyes of Nina, a little girl who wanted to play in that park, a little girl who came out to a meeting to tell city officials why she felt sad because she couldn't play in her neighborhood park like some of her friends could. We believe that storytelling and telling the neighborhood of people who are actual clients, who are impacted by program initiatives, is an essential part of data collection. A little postscript to the whole video as well. Since that video was made and since that work started, I always like to give a shout out to the Roseville City Council. They allocated $10 million to completely reimagine and renovate that park. It is now leveled. The whole community engagement and listening process happened again, reaching out to people to say, if we reimagine this park, we now have the money to do it. What would you put in it? What would you want? What kinds of activities do you want in this park? So when I was there 2 weeks ago, the whole park is leveled now, and we are very, very excited about what has come about, really, with Nina, the little girl, identifying to us that it is about playment, is it about connection, it is about being with others, and hearing that over and over again from residents in this neighborhood. Next slide. This, too, is a continuation of Nina and her grandmother, and this story comes as a result of a joint project that Dr. Aguilar-Gaxiola and the Health Education Council have been embarked on. It's a program called Mente Sana Vida Sana. It is implemented at the Sacramento Mexican Consulate. We took this and said, how do we take something, an instrument that's used primarily clinically in the doctor's setting, the patient health questionnaire, the PHQ-9 depression scale, and take that out to a community setting? What would happen with that? We've tried that. We arranged follow-up services. We provide, through our partnerships, on-site counseling in Spanish for those who need it, up to 5 sessions. What we found in implementing the PHQ-9 was that most people didn't need therapy. What they wanted was ways to connect and gather with others. And so by listening to them and implementing that and hearing, what do you mean when you talk about you'd like to talk to others? Does that mean a therapist? Who is that? What that has resulted in is this story tells the story of Nina's grandmother who felt sad and lonely, and Nina noticed this difference in her grandmother. What that's led to are women's art groups that are held at the consulate and in our office, a sewing club, ways and places and spaces for people to gather and connect to. And we do think that is contributing to mental health wellness in our community. Next slide. So just a few lessons learned. Community engagement is all about trust, history, relationship. It is about building trust. How do we build trust? We build a history of doing things together. We build a history of listening and doing and acting together. That builds relationship. What matters? The messenger matters. The approach matters. How we enter and exit a community matters. Listening without an agenda, acting on what is heard, pivoting, allowing ourselves the flexibility to pivot when we need to. Meeting people where they're at, where health happens in communities and neighborhoods. I know that one of the lessons is that change is incremental. Offering visible changes to people makes a difference. showing evidence of how listening is happening and how what people are saying matters. Number 6, asset resilient based, listening and assessing. You know, I read a couple of the documents in preparation for this, and I noticed in the RAND report there was a quote by someone that said, "We need systems attuned to what people need." And so much of our data is based on needs and deficits, and what services and programs do we offer to answer those needs. I think data collection also needs to be asset-based. What is happening in your neighborhood? How do we leverage relationships, groomings, places where people already meet and congregate? How do we better document and approach and relate to community? As much to provide services based on need, but also recognizing that all communities have assets that they bring, many of them that are health protective and mental health protective. And finally, people want to contribute and sustain what they help build, which for me is another reinforcement to double down on community engagement, authentic community engagement. Thank you.
Thank you so much to all of our presenters. And Dr. Quist sends his apologies. He had to step away to attend to a consumer matter. So he hopefully will be back. But
Thank you. So at this time, Commissioners, if we have questions or comments, and I'm just going to start with one. I'm hoping, we had one from Dr. Danovich, and I'm going to pose it. And this question is for Stephanie. First, let me say thank you, everybody, for your wonderful presentations and information. And I know we have a lot of interest in questions and comments from our commissioners. And I just wanted to start with Dr. Danovich. The question is with respect to substance use integration. How do we ensure that we are not just talking about adding services, but also talking about integrating into our approach to financing, workforce development, prevention, accountability, and communication? So in other words, how do we ensure that it's deep and vertical integration? And how can the Commission specifically help DHS overcome the obstacles that they anticipate in implementing the plan?
Well, I never pretend to channel my colleague, State Medicaid Director Sadwith, who I think was here a while ago, and I know you guys are going to take up this issue later in the process, so I'm not going to be able to speak to it with the level of expertise that he can. But what I can say as part of agency's responsibilities is that we are talking about this across our department. So you mentioned part of literally what I did before I came here was sharing a variety of different workforce assessments that DHCS has done over the years with our HCI partners, specifically looking around the SUD workforce. I think some of the conversations that we've been having internally have really been about the opportunity to do more integration, especially in that space around FSPs, where there can now be, needed substance use treatment for somebody. It's not like they didn't do it before, but to really use that model as a model to really look at how to integrate care, both financially, clinically, and through the workforce. So those conversations have really happened in that space. And so that would be one area that I would recommend, since you are selected, or we need to collaborate and get consultation from you. So I think that's something that's extremely tangible that I could share. Also, we should talk about ways in which you may want to be involved in some of the workforce strategies that we're working on. I really welcome, these are very important. It's important to hear from the commissioners. But a lot of the work is happening on the day-to-day basis at the staff level. And so we really should find ways to connect in that space. I can tell you now that my my calendar is full with at least one Prop 1 meeting a day. So working with our various different departments. So let's figure out how to do that in real time in a more meaningful way. And I guess the only other thing I can say to you, Commissioner, in response is, I know that you have heard this from us before. I have kind of my top 5 opportunities with Prop 1, and SUD integration is in that top 5. And I think that I will channel my colleague here who had to deal with an emergency. I've heard that also from the counties, that they see truly getting to integration and leveraging some of the existing work and ongoing work that we're doing in our Medi-Cal space to make sure that we're really integrating SUD and mental health services. So let's keep talking about it. I know it's a passion of yours.
Thank you, Stephanie. Commissioner Brown.
Thank you, and I know we're really tight on time, so I'll make this quick. But first of all, great panel. I really enjoyed the presentation. Great video, really crisp and to the point, great graphics. Whoever put that together, really good job. And thank you all for not only being here, but for the work that you continue to do. And that photo from 20 years ago really showed me that you have all, the 3 of you that were in that photo, Daryl and the 2 of you that are in the center, have weathered 20 years of service very well. You're remarkably well preserved. So keep doing whatever it is that you're doing. The question that I have was on the regs that are coming out in terms of and really the question is pretty much, why are the equity related data mandatory for county reporting and the incarceral and the homeless data optional? I see that as problematic, that you're going to have partial responses. It won't be as meaningful to be able to look at it from a statewide basis.
Well, there are lots of reasons. I think we were really hopeful that even though it's not mandated, that it's something that becomes something that everybody does. I think that at the state level, that those are the kinds of measures we will be looking at on a statewide basis. We have ways in which we can do that. I would really encourage folks and those listening out, as well as this body, that again, while there are certainly new and important levers at the state level to do accountability, especially in the area of collecting information about our resources, there still are going to be a lot of decisions that take place at the local level, including, what, and I don't want to say, I actually think on this particular issue, as you know, I know it well, this is a problem in every single community. I mean, I don't want to pick on Alpine, but maybe not Alpine, our smallest county in the entire state. But I do think that counties, to a certain extent, have to focus on their priorities. What I would say about this, while it's not mandated, going back to those target populations, people who are justice impacted, and in particular, people who are coming home from incarceration, are priority populations. I don't know how you can be held accountable to your priority population if you're not also looking at that data. So to be honest, I expect that communities will select to include it. But again, it was not something that we had the capacity to mandate.
Well, if you have any chance to tweak it between now and when it's rolled out, I think the Sergio's suggestion was good, that maybe a rewording of a may to a should, and because I think that if it's may, it's just going to be seen as optional. And as much as every county, person that's putting these reports together has on their plate, that's just going to not happen at a global level. So I really would encourage you to try to revisit that.
Thank you. Thank you. I'm sorry, Commissioner Chambers, please.
Thank you. I'm just going to make a thank you for everyone that presented. Some of the things that stuck out to me that I just want to highlight for us to think about, when the first thing on the children's data, or the data about the engagement, and where is the engagement at in the commercial plans with children and families. And I like to uplift the point about, are we asking children and families, are they really enjoying the services, or that was really important. And then with Prop 1 implementation, I'm really interested in working with the agency on the stakeholder process. And like Stephanie said, a lot of this stuff is happening at the local level. I think as someone that's like a Black Californian, when this law was implemented, everyone was confused. People are confused right now on the ground. Consumers are confused. I think counties are working very graciously with the agency on trying to figure out how do they engage their stakeholders. But to Ryan's point, like, how do we track this data, or how do we present this information to the community in a way that's equitable, like, you know, and just culturally appropriate? Because I just feel that that's going to be like a show across 58 counties with these 3-year plans. And how do, like, I don't know, I just really want to see if we can be intentional as a commission, or what guidance we can support with the counties to support them and support our people. And to your point about engagement, I'd like to, Mona mentioned like the 28 tools, just because it's come up so, once again, engagement and committee with, you know, us going to where people are. Like, I know people say meet people where they're at, but we still are missing engagement. I really like the walkability example, but like, do we have a way to really go to the jails, to go and find out what people need? And this uplift in the role of lived experience with family members and consumers. Like, please don't lose us in this, and us just not be, oh, we're going to include the peers. The people with lived experience, like you said, are the ones that know what's happening. They know how to connect. And I think some of the rhetoric that I heard around like peer support services during the transformation is like, oh, they're just doing art groups and sewing classes. But what you just uplifted and highlighted, the main priorities that people wanted was they wanted to gather with each other. They wanted to connect. They wanted community. Those are all core things that we as peer supporters, as well as community, but our workforce really puts that. And so I just want to uplift that, like in the medical model, what does that look like? And moving forward with transformation, uplifting the role of lived experience. And I have more, but I just wanted to thank you all for your time, and I'm committed to that. Thank you.
Thank you, Commissioner Chambers. Please, Commissioner Bontrager and then Commissioner Rolette.
Just a quick comment about data and this transparency report. I'm all for transparency and data-driven decision-making, but I'm concerned about the implications of it. You know, in healthcare, I say we have a fire hose of data. And my metaphor is there's a fire and the fire hose is laying on the ground, the water's going in the gutter, and all the firefighters are standing around saying, you know what we need more water. And that's what I feel like sometimes when it comes to data, that's what we look at. And why is that important? You know, in the 24 counties that I represent in our Medi-Cal managed care plan, many of them are rural. They don't have the capacity administratively to do many of these things. And so every dollar they spend on reporting outcomes is a dollar or a resource that they don't have to actually provide a service. And I don't know that that's always represented here in Sacramento. You know, we talk a lot about DEI, but one inequality we have is structural inequality between rural and urban. And that's real. And as we up all the requirements, I'm afraid that we're not going to allow, we're going to exacerbate that inequality. And I see that with some of our efforts around our school engagement with SB HIP, where some of these schools are literally one-room schoolhouses, you know, school districts of 11 people. They can't avail themselves to some of these resources because they don't have the administrative capacity. So as we look at some of these things, I just hope we keep that in mind, that they can play in this arena as well and avail themselves of all these resources without taking away from services.
May I comment on?
Please.
Okay. So, and this would also speak to Commissioner Chambers' comment. We are definitely asking a lot more of counties. And the state took 2% out of our state admin funds to send it to the counties so that the counties had more resources. One, to do a robust community planning process, but also to comply with these reporting requirements. One of the conversations we had in the workforce space was, this isn't just about clinicians and building clinicians. It's also about how do we redesign and support systems to be more effective in basically like what Dr. Quist would say if he was here, being an effective managed care plan while living in a system where you're also the community safety net. So we do need people who are data experts sitting here and doing this work, not just somebody who's a clinician who also has that responsibility. So I think when we think about transformational change, we have to really think about supporting our county partners to truly transform into being more effective at what they've been asked to do. So capacity around data, capacity around administration, capacity around performance improvement, not just the delivery of direct care. I don't say that to disregard what you're saying, because I think we have a particular eye towards trying to understand how to make everything from exemptions to regional approaches so that our rural and smaller counties can have the flexibility that they need to be as successful as they are, and recognize that they're different. But I think we're more globally trying to think about how do you do this. That doesn't necessarily speak to the fire hose analogy, which I think is really excellent. We hear that in every place and space I think that we've been in the last several months on this topic. And I'm not leading those efforts. I'm frankly not even very involved in those efforts, so I can't speak to them with a lot of specificity. But I do know that these are all themes that will be taken up, and I did confirm that work starts in September, that I hope you guys are really ready for. But I don't know if that was very succinct, but I think what I was trying to say is that I know it doesn't help just to give people more resources to do more stuff. We can't just think about it that way. I do think that we're really trying to work with also our partners at CalMesa really closely with counties to figure out how do we do this in a way that also supports our small counties and gives them the capacity as well.
Commissioner Rolette.
Again, to repeat what's been said, thank you so much to the panelists. Good to see you, all of you. Sergio's been a while, and you are still getting younger, so I appreciate that also very, very much. First, I want to say that the presentations that emphasize the importance of the perspective of the end user, I really want to highlight that, because as a community-based organization providing behavioral health services for over 5 decades now, or almost 5 decades, if you don't shut up and listen to the end user, you don't understand the importance of the disconnect between the key performance indicators or the outcomes that you desire and just how they navigate achieving behavioral health remedies to social determinants that are everywhere. And I just want to make sure that I make 3 points, and I want to be very, very clear. I want to ask that we elevate the information that comes from our 2 really prominent committees. That's the Consumer Peer Committee and the Cultural Competence Committee, because there is a perspective that we can glean there from the end user, the people that really are utilizing Medi-Cal to navigate behavioral health and healthcare and understand their perspective and the challenge there. And that's easy for us to do that because it's our committee. Second, I think that there are key performance indicators that they will speak to, especially as it pertains to utilization of services provided by managed care plans. Tyler has referenced managed care plans, and I may misquote him, so please forgive me, but he said at our meeting, managed care plans are highly capitalized, and there are some expectations associated with that assertion. So having them come to speak to the implications of that and the benefits associated with being a recipient of services provided by a managed care plan, I think is important, and I think it's something that the commission should listen to, because there is an indicator associated with my benefit that's being provided by a managed care plan and how I navigate that benefit that would be helpful for us to hear how the end user experiences that. And then the last point I'll make is related to workforce. And Commissioner Carnevale has talked a lot about AI and how we utilize AI. And there are a lot of opportunities to enhance the experience of today's behavioral health workforce, incorporating AI into the work that we do. And I would encourage the commission to think about that and think about how they might help as a convener, but even in other ways to get people to talk about the utilization of AI, because if you ask a provider of behavioral health services, what's the chief challenge associated with yes, you just said it, documentation. They're going to say, they'd all say documentation. And it is, if it is the chief challenge, then we should be talking about that more prominently and how we incorporate AI in ameliorating that challenge, because that's fundamental to the workforce. And as Stephanie indicated, not just for clinicians, but in every sector of the behavioral health workforce, it is the number one articulated challenge. And then I'll go back to where I began. It is so important. Sergio is right. You have to be prepared to shut up and listen to people and understand that that's not just a colloquialism. It is fundamental in the delivery of these services, because people will tell you, they'll even laugh as you indicated, we don't have a food desert. We have safety issues. We have poor lighting in our neighborhood. We have a lack of safe, affordable places to live, and we're preoccupied with that. So when we get up at noon, we're thinking about where are we going to sleep tomorrow, not where we're going to get our food. And it's those kinds of conversations that I hope the commission can help the department have going forward.
Thank you, Commissioner Rolette. Commissioner Carnevale, please.
Thank you, Madam Chair. So many things I could say. I'll try to constrain myself. First of all, since Stephanie called me out, I do want to acknowledge I'm really impressed with the movement of the words and the mindset that's being expressed here, particularly talking about outcomes, and so I appreciate that. While I continue to be frustrated, we aren't further along, excited about the possibilities, and appreciate everything that was said by everybody today. I think, and I always feel, as the business guy, I always feel a need to apologize, because this is the least exciting stuff we do, and yet it's so foundational to everything. As Sergio said, if you don't measure it, you can't impact it, so you've got to do that. And I'll just put in a plug, particularly since Commissioner Rolette mentioned that, the opportunity here is that, as I think Ryan was said, we've got this antiquated system in the 21st century, and we do have this incredible technology. What it allows us to do is, we used to be blocked by systems that didn't talk to each other, and there was no easy way to get them to communicate. Today's technology allows you to suck up data to the cloud and analyze it and do a lot with it, and to document it faster. There's so much potential there, and the next 5 years it's going to be accelerating, and we are crazy if we don't take advantage of that, because that's capturing costs that you can deploy to other things. Having said all that, and here's the thing I want to elevate, and this is not to take away from anything that was said by my fellow commissioners about community engagement and focusing on the end user, because that is critical. That is the North Star to all this. But to Commissioner Bontrager's point, you've got this data, this fire hose that's disconnected to the fire. And here's the piece that I don't see elevated. When you talk about data, you can't only look at the data compliance and requirements and needs around the end user. You've got to look at the system that is the delivery mechanism. Otherwise, you can measure all this data and discover what we already know, which is we're basically failed in almost every metric, and we don't have anything actionable to fix it. And so, while you're measuring what's going on at the patient level, we have to be measuring the system, and there's no blockages to that. We can be doing that tomorrow, but, business struggles with this just like government does, and good businesses figure out ways of measuring employee and departmental and company level performance, and we should be measuring it. We should be creating transparency. There should be no blockages to our ability to report it, because all of the work in business shows that if you run an organizational well through those kind of tools, then the outcomes that you're trying to get to will be delivered. People will deliver it. But a lot of times they don't have the tools to see whether they're pointing the fire hose at the fire. And so, that is, and I don't see that elevated here. It's a whole nother body of work, and it's work around how you run the organization. And I'll just wrap up by saying, I don't think it's just important to data here for mental health. I think literally our presidential election is about this. It's about good government. And the research shows that in 1960, most people trusted government, and today it's single digit the number of people that trust government, because they don't understand it, they don't understand why it's not delivering solutions, they don't have transparency to it, and they don't think government is good. Data is our key, and data to the performance of our people that run all of us that have a role in running the system. That's the key to proving that we have good government, or that we can get to good government. So to me, this isn't just a discussion about data, it's discussion about democracy. And so that's why I get enthused about it, and I thank you for everybody's comments.
Thank you, Commissioner Carnevale. So I just want to make, again, I want to say thank you, and I do have just a question. And I want to go back to data too. I think that we also have the data of the people that are currently accessing the system, and there's a whole lot of people who are not, because the way the system's created. So we only have a partial picture. So while we're saying, there's a lot of data, but there's a lot of missing data, because the people who need it are not even within the system. So to that point, when the commission held hearings on legislation that put Prop 1 on the ballot, we heard community concerns over and over that the legislation was not going to be informed by community voices. So my question is, how will agency ensure community voices inform implementation, and how can we help? Because, I've heard in the past, well, that's this great partnership, and the community trusts the commission, and we have open doors, and we always ask for community voice. But that's different than them being in front of agency and really speaking directly to agency. So that's my question. How will agency ensure that? How will agency ensure that? So that's one part of the question, please.
You guys have a committee structure as well as a series of contractors. If you want to, we don't have capacity, like people, literally, to be available for all of those. But if you want to host things, you want to write things, you want to collect voice, we will consume anything that you produce. I'm being totally honest, but we do not have the capacity as a policy outfit based in Sacramento to deploy ourselves across the state. So I think we're looking for partnerships with your organization. I see Jenny in the audience, who represents the California Behavioral Health Planning Council. We have another body that represents all of the local boards and commissions. And so I think we are definitely thinking about it. We are having conversations with other community partners, foundations that might be able to do this on our behalf, because it's not something that, frankly, I don't necessarily, I deeply appreciate what you said and believe it in myself personally as someone who's a social worker. Obviously, as you guys know, worked in this field for a very long time. But we have a commitment to, we're doing policy work in Sacramento. So I think we are open to any ideas on how you could bring more more community voice to us in the process. And I think it needs to happen fairly quickly. I mean, we don't have committees like you have, like you mentioned, I don't know how many committees you have anymore, but you have your client and family committee. We are hosting monthly listening sessions on topics, and I have said this to other bodies as well. Take that content and dive into it and give us feedback. We have an email box. We'll have a presentation at our behavioral health task force, which has 60 plus members from 60 different walks of the system, from veterans to first five, et cetera, really making sure that people know where to provide input. But I think that would be really helpful. I don't know exactly the scope of the contracts that you have with your stakeholder groups that try to reach voices of people. I know that you have like veterans and underserved racial and ethnic communities and different ones, but I think that it would also be very helpful for those groups to do exactly what Rochelle was mentioning before, which is making sure that the constituencies, so to speak, that the voices that they represent to all of you are well informed and prepared for the local process. And we are thinking about how do we do that and do that responsibly, because while nothing, so to speak, is implemented in terms of a significant change, other than like your name change and starting to get some of your new membership, the policies of the BHSA don't actually go into effect for the most part until July 1, 2026. So how do we have a run-up to that, making sure that people are informed and ready to be a part of the process? The state policy, just to be clear, we will put out our first set of draft guidance to chomp on before the end of the year. So it's going to be soon. We don't have a lot of time because we have to give guidance to the county so that they can start their process. So I do really encourage you. I think you have a lot of tools at your disposal to start getting us feedback, and we do review everything that you submit.
So we will definitely continue to partner with you and come up with ways so that agency is getting informed. And I just want to really lift up the consideration of the recommendations for the toolkit using those 28 instruments. When we say, here's evidence-based practices for community engagement, then I think we should really honor what we've learned. You've been in this, Dr. Aguilar-Gaxiola, for years. When we are counting on counties to say you have to have community engagement, and without putting a framework around that community engagement, then community engagement in San Diego County versus LA County versus, Kern County can look vastly different. And I think we should just really support some best practices in what that looks like. Because again, we are not tapping into many of our Californians who really need it, because it's just not, the system's not created for them. It's just not welcoming them. So if we could keep that at top of mind, I would think it's important for all of us. So
I'll share that toolkit with all of our departments too, because they're the ones who are starting to think about their community engagement processes for their different responsibilities. I think I will have it, right? I wrote it down, but
we'll
I'll
make
just
sure
reach
you
out
have
and get
it.
to you. Okay.
Yes, for sure. Thank you, Stephanie. Thank you.
But just one more point. I think, though, I like your point, Stephanie, about like utilizing the contracts that we had. And then I think a call to action for anyone that's listening, or government body, hire the community, hire the promoters to go out and talk to monolingual individuals on their things. So I like the commission, our committees that we can utilize, because I'm a part of the client and family one. I just would really I think it'd be not innovative, I don't know, just common sense to hire us to do it, the people to engage and work with government. And it would also build trust, because, but that's just me. I can go on and on. Thank you.
Thank you so much to all of you for being here. Yes, please, Commissioner Gordon.
Just a very brief comment. I also appreciated the presentation, and And Stephanie, I think your department has done a first-rate job of trying to organize something which is incredibly difficult to organize. But I'm just wondering, as we talk about creating better data, better this, better that, those are the things that enable something to happen. And when we get to what are our end goals, I think it would be helpful to, is it much better access to services? Is it a focus on prevention rather than treatment? What are the sort of North Star goals of revamping the system? You know, obviously, listening to the customer is one, but I think it would be really good to have, apart from just the transactional goals, we're going to have better data and so on. What are the outcome oriented goals that everybody can say, well, this is where we're headed.
So we're creating those statewide goals and around quality and efficacy is actually one of the requirements for us to do as part of that data and metrics piece that I was talking about. It was written in the statute, but also I want to not push back, but I want to encourage all of you to do it as well. Start doing that activity. You're going to be a part of the process, and I think I'm still getting, because I'm preparing for today, thinking through, and we'll take back and need to have conversations with leadership around what does it mean for us to coordinate with you to drive a research, what are the 3 words? I forgot. I have them right in front of me. We have a responsibility to work with all of you to create transformational change through research, evaluation, and tracking outcomes. So like, what does that mean? These conversations outside of this room, like what does that mean? How do we do that? Is that part of or separate in addition to what needs to be done through that responsibility that I just mentioned of creating those statewide goals? So I want to encourage you all to think about it and give us some ideas about what that looks like. And I will be here, and obviously you all know that I report to the secretary and can make sure that we are continuing to have that conversation in a very robust way. That's all I can say.
Thank you, Stephanie. And to that end, I'm going to ask that Toby, please give us some ideas to consider on how the commission can really support community engagement. So if you could take note of that, and we'd appreciate that. Thank you, Toby, very much. Again, Stephanie, Dr. Aguilar Gaxiola.
Sergio, please.
Sergio, please. And at this time, we are going to move on to public comment. Commissioners, thank you. We're going to move on to public comment. So at this time, Mariani, if you can open the queue, and we will take public comment, first in the room and then online. Mariani, do we have public comment?
We do not have any public comment in the room, but we do have 3 virtual comments. The first comment we have is from Richard. Your line is open.
Richard, go ahead, please.
Hello, this is Richard Gallo from Santa Cruz County. I'm a person with lived experience and a peer support specialist, and I'm a former youth peer counselor in high school. What I wanted to mention for the commissioner to consider regarding the FSP, since it's being funded, that you standardize the data collection. It needs to be done, and it should have been done all along, because you need to know what are the positive outcomes, since a lot of money is being spent with this. Secondly, peer support specialist needs to be part of the FSP requirements, because you're talking about individuals with lived experience of being homeless, individuals with lived experience of justice involved, individuals with experience of substance abuse that can help their community in maintaining or improving their recovery. This is what's being left out. I strongly believe that the state needs to look at it to make a mandate that a percentage of its workforce needs to be peer support specialists. Not that they were required to do the Medicaid billing, but without the Medi-Cal billing. The other thing is, I have mentioned this to the Oversight Commission about data collection, looking at Centers for Independent Living, known as CILs, of independent living outcomes. Check with the Department of Rehabilitations. That's who the Centers for Independent Living are funded by, where you can utilize, copy someone else's without reinventing the wheel. I have mentioned this to the commission in the past. I gave my 2 cents to get this issue of data collection resolved, up to speed, caught up. The issue with statement that Stephanie Welch mentioned about the bold move by the governor. The bold move was done without the peers, without the peer workforce community involved. We were excluded. The Department of Health Care Services, Department of Health and Human Services did not include us. What they don't realize is peer workers make a positive impact with our mental health community. This decreases hospitalization. This decreases justice involved. That's why peer support is critical in helping them maintaining their recovery. When it comes to families and children's, you're not talking about SCD population, but you're also forgetting about individuals with intellectual disabilities, dual diagnosis mental health. Families are struggling with the behavioral piece part, and I have mentioned this to the commission in the past. I gave my 2 cents to be aware of families struggling to get behavioral health services piece. Look at the program.
Thank you, Richard. Your time is up. Please wrap up your comment.
Okay, look at with the County Santa Clara. That's critical. That's important. Community planning process needs to be more involved. Peer workers need to be part of Proposition 1 when it's no regulation that included us with Proposition 1. So that says a lot where the state stands. Thank you.
Thank you, Richard.
Next, we have Jay. Your line is open.
Hi, Commissioners. My name is Jay Calcagna. I am with the California Council of Community Behavioral Health Agencies, which also serves as a convener of the MHSA Partners Forum Stakeholder Group. First, we'd like to echo Commissioner Rowlett's comments about raising up community engagement as part of transparency and accountability for the Behavioral Health Services Act. And CBHA is also proud to represent behavioral health providers from all over California. It's essential that providers and agencies continue to speak on the nuances and shifting paradigms within the behavioral health field, especially with the passage of Prop 1, and identifying necessary metrics to protect California's most vulnerable communities. We also support the need for continued transparency and accountability within the behavioral health continuum of care, and we appreciate the conversations that we've been hearing today. We hope to continue to be a part of the conversation around bridging access to care through increased transparency and accountability. Thank you for your time, and I will pass it along.
Thank you, Jay.
Next, we have the phone number ending in 319. Your line is open.
Yes, can you hear me?
We can. Please go ahead.
Thank you. This is Steve Leone, consumer and advocate. And such great things, some of which I would disagree with, some of which I would not. Wonderful stuff. But I want to focus on one thing. And I'm very glad you brought up about the idea for having community voice and client voice, family voice. But I want to point out that that's often conceived of, I mean, even though I approve of the idea of shut up and listen, so you say, well, we'll do a listener session. And the problem with that is that, you know, the word culture is often associated with ethnic distinctions. And it can also be your place in life, your wealth status, your, disability status or not, and county and state personnel are often living in a different cultural world in a sense than the consumers and family members are. And this has to do with the concept of cultural humility, which is often forgotten. That means that you have to look at your own biases when you evaluate someone from a different culture and realize you're seeing or hearing what they're saying through your own lens. So what's really needed is not just a listening session, but a dialogue, a conversation. Very simple. It doesn't have to be full of rules and everything, but it's a simple conversation to make sure you're really understanding and to make sure that, well, if you're saying, I want you to do this, and you say, well, we can't do that. And they say, well, you know, that's not what we really want to do. And you go back and forth, and finally you find something that you can work. You have to have that conversation, not just listening. Thank you so much. Bye-bye.
Thank you, Steve.
And our last public comment is Laurel. Your line is open.
Hello, this is Laurel Ben Hamida again from Muslim American Society Social Services Foundation and BRIMCO. Very good presentations. I wanted to make a few quick comments. The data needs now to include a new category, Middle East and North African, MENA. And if you are not up to speed on that, CPEN did a very good webinar on the census, the federal requirements on this, and then there may be state requirements coming up as well. And I think it would be good to have a presentation on this actually to the commission. This would apply to new regulations. When the PEI regulations came out before, they were not up to par. Let me just be kind. Second, in terms of corrective action before behavioral health action plans, I think it's great that you can do corrective action because probably in about 5 years, the Little Hoover Commission will want to look at what you've been able to accomplish because that's been a problem with the MHSA in the past. And you can go back to the Little Hoover Commission's previous work on this. Thank you to Ryan Quist, who's really done a great deal in Sacramento County for community-based organizations. He stated the importance of this aggregated data. He talked about the federal and state levels. So I think his plea to have, maybe he wouldn't call it a plea, his hope that data, out-of-date data formats would be taken care of. And legacy data systems being revisited will be listened to. There were also additional comments on measures and scrutiny and the importance of standardization. That's something I've been emphasizing at the Care Court work group and ad hoc work group meetings because there does not seem to be a standardization across counties there for handling language interpretation and translation issues. Thank you very much. Really a very, very good panel. And those I didn't say anything about, it's because I thought you were doing a great job. And I love the video. I can think of several people who are active who will really benefit from it. So thank you. And I hope you get some lunch.
Thank you, Laurel. My fellow commissioners, we are a little behind schedule. I'm going to ask we take a 10-minute break. Lunch is in the other room if you want to grab that, and we will start again at 1 o'clock. So if you pick up your lunch, and we'll just work through, have a working lunch. So back here in 10 minutes. That need to be made before next year. Kendra, welcome. Please go ahead.
Thank you. Good afternoon. As the chair said, I'm Kendra Zoller, Deputy Director of Legislation, and I'll be helping the Commission roll out implementation of Prop 1. My PowerPoint will provide a very high-level overview of the changes. Your handout that looks like this, the reference guide provides further detail should you need more information about each of these changes. So you'll likely recall that Prop 1 was approved by the voters in March of this year, and it has a rolling implementation over the next several years. This table gives you an idea of implementation dates for the changes affecting the Commission. Most of our implementation is on the earlier side, starting January 1, 2025, which is about 5 months away. So since the Commission generally does not meet in December, we have 4 Commission meetings left right now before some of the largest changes happen, as in our expansion to 27 commissioners. Today, I will go over all these changes, but focus on those that occur January 1 so we can hear from the commission on these items and so you can take action where necessary. Some of these are information only and some will need to be brought back to the commission for further discussion or action. We do have placeholders on the agendas for the next several months to discuss any of these items. So please feel free to make suggestions and keep that in mind as I go through the presentation. Okay, so January 1, 2025, the commission will have a new name. This is partly informative to give you a heads up that we will be updating our website, email addresses, documents, contracts, presentations, letterhead, our sign outside, these table linens here. But this is also an opportunity for commissioners to discuss informally using an abbreviated name. I think everyone can agree our name is long and a bit of a mouthful. And some of our other state commissions, like First Five and the Little Hoover Commission, also have long names, but they've sort of branded themselves using a shorter name, which is beneficial for the community. It's easier to pronounce, easier to say. So we would be interested to hear what commissioners think about that, and I'll circle back to this one at the end of my presentation. Okay, so this is the big one, and arguably should be our priority today with our expansion to from 16 to 27 commissioners. We want to make sure we're all well prepared to accommodate our new members, bring them up to speed, but also just logistically function as well as possible. Under the new Bagley-Keene law, beginning January 1, we will need 14 in-person commissioners for a quorum, which may pose a challenge with 27 different schedules and locations. I will note that the Assembly and Senate commissioners are able to appoint designees under Prop 1s, which should be helpful since their current schedules make their attendance very difficult. The legislature also recently codified that the commission can take advantage of delegated authority so that the chair or the executive director can move business forward. So that will also help, but it will require the commission to update their rules and procedures to determine what that will look like. We can also potentially take advantage of our committees and subcommittees to move some business along. And with 27 commissioners, potentially comes 27 priorities, which will be great in a lot of ways to have a diverse set of background and voices. But in order to be effective, we will need a way to focus our efforts, align our priorities, and ensure our new commissioners have a solid understanding of what we do and how and why. So it might be most appropriate to sort of kick off that effort by having a more robust onboarding process for both new and current commissioners to do all of those things, but also get to know each other. So I will get back to some of these items here at the end of my overview, as they'll be the focus of today. This slide is largely informative, but of course, feel free to discuss. Under current law, the commissioner advises the governor and the legislature on mental health. Under Prop 1, that's expanded to substance use disorder. As you know, the commission has already started work in this space with our SUD pilot program. But with this expansion and the elevation of integrating SUD and mental health, our 4 new SUD-related commissioners, we expect this to be even more of a focus in the future. Our data statute is slightly stronger, as you can see in your handout. It also includes our current and pending data use agreements, so we hope this language will help us with our research and policy reports. The Behavioral Health Student Services Act grants will be expanded. We will also have 3 new members to our Early Psychosis Intervention Advisory Committee, which I've listed in your handout. And our fellowship will be expanded to include SUD consumers and professionals. We are already required to develop strategies to overcome stigma and discrimination. Prop 1 will require us to work with our partners at the Department of Public Health on those efforts. The commission will also provide TA to counties on implementation, planning, training, and capacity building investments, including on innovation. We've already started some of that work with our discussions about using innovation dollars to support transition. Stephanie mentioned the state audit in her presentation, so that'll technically begin in 2025 with the first report out in 2029. We expect to be audited since we are part of implementation, and more about that is also in your handout. And also as an announcement, the Revenue and Stability Group that Toby will be participating on, they just started and their first report will be January 1, 2025. Okay, so moving quickly to July 1, 2026, that's when the MHSA buckets shift over to the new buckets, which includes the deletion of the 5% county set aside for innovation, which the Commission currently approves. However, our role in innovation will not end and is arguably increased with the start of our Innovation Partnership Fund. And as you heard in announcements, the Commission has already started exploring a lot of exciting opportunities in this space. With the shift to the new buckets in July of 2026, the Commission will also play a role in determining priorities in several areas with our partners. I've listed some of our work we've already done in these areas that we hope to continue to elevate. And obviously, we talked a lot about that today with data and accountability. And since the Commission provides oversight of the behavioral health system more broadly, we also have the opportunity to lean in on other priorities that are being elevated, such as workforce, accountability, fiscal transparency, community engagement, and planning. 2030 seems far away, but it will probably be here before we know it. That is when 3 of our new reports are due, as listed in your packet. And we have a chance to elevate what we've learned and shared it with the governor and the legislature and others, which by 2030 will be a new governor and probably new legislators. This is also informative in future years. The Commission will continue to receive county plans, currently called 3-year plans, but will be called integrated plans under Prop 1. More information on that in your handout as well. And then we will refer county performance issues to DHCS for potential enforcement. It's a part of the report card, as Stephanie mentioned in her presentation. And they will use that for corrective action plans. And as I mentioned, the first audit report will come out in 2029. That's a typo on the PowerPoint. Okay, that was a lot, but I hope it was a helpful high-level overview. As I mentioned earlier, January 1, 2025 is about 5 months away. So after talking to the chair, we'd like to hear from the Commission on these first 2 questions regarding the name change and expansion to 27 commissioners so that we can begin preparing for these changes as soon as possible. And if time allows, we can also discuss some of the other items or leave them for future agendas. So happy to answer any questions. Thank you.
I have just a nuts and bolts question. How do you, I guess, Toby or the chair, with 27 of us, I know at least for me, I highly value my own input. If we have 27 of us equally highly valuing our own input, how will we manage an agenda, just given that volume?
Good question. I appreciate that, sir. And I appreciate that you really asked Kendra that question. I think what we're trying to do, the conversation we want to have, and it's a bit of a challenge because we're having the conversation with the commissioners in place today in anticipation of a different membership 6 months from now. But we also recognize that, we don't want to start January with 27 commissioners with a conversation that says, okay, now that you're here, what do you want to do, right? And so for staff, this is a planning conversation that can inform discussions or decisions that you can make today and then we can roll out with the new expanded membership, or that could be tabled until January when the new members are here. But to answer your question in that context, we're thinking through how we separate out the decisions that you're most concerned about versus the decisions that maybe take time but you're less concerned about. And that allows us to move the less significant issues either onto delegated authority to the staff, delegated authority to the chair, or through some sort of a subcommittee structure. We recognize that as new requirements are put in place for in-person participation, that it's putting constraints on our ability to achieve a quorum. So I think about that in terms of ensuring that the work we're doing is so sufficiently exciting and impactful that it warrants your time. You are all, highly talented, very busy professionals who have risen to the point where the governor is appointing you. And so we want to make sure we're earning your time. But there's other things that we have to do for, just procedural rules. And so we want to figure out how can we separate those so that the stuff that's on the table is essential and important. And then within that, it's about, facilitating a discussion, and that burden really falls upon the chair as leading the dialogue, and then, of course, creating some culture of process and respect among, because, there are other large bodies. Sometimes those meetings are really smooth. Often that's for less significant, less controversial issues. Other large bodies on very significant controversial issues, they're less smooth, and I think, you've understand that comment.
So in short, essentially, for us to get our work done, you have some heightened delegated authorization to kind of discriminate what comes to this body and what doesn't need to come to this body, in short.
Yeah, and so I'll remind everyone, because it's been some time, and so the comment about onboarding new commissioners, the questions around strategy, timing. So the law today, under the MHSA, says the commission may meet 4 times a year, or as it sees fit. And historically, we've met 10 times a year, and we've tried to do sort of sidebar conversations on the Wednesday before site visits, those kinds of things, because of that value. That was easier to do before the pandemic because nobody was considering the idea that you could, participate online, right? And so now our culture has changed, our expectations have changed, your workloads have changed. And so, we're trying to find that sweet spot. And so you have the authority to not just think about delegated, how decisions are made for the things that are formal, like, spending money or approving things, or we're required today to put almost everything in front of you. Which is why we try to package it in terms of the budget presentation that Norma gave today. You also have the authority to decide how often you meet. You don't have the authority to decide how you meet because the statute has been changed that we have to have a quorum in person, right?
Is there any possibility that that's going to change to update with current times? Because it's completely out of step with the rest of the world.
What's the genesis of that?
Yeah. Or is that locked in for some legal reasons?
It is legal, right? It is locked in for legal reasons. It is, at the discretion of the statute that the governor and the legislature put in place recently. It's in response to some very real historic issues about public agencies operating in public with what friends of mine in the local government committee sort of referred to the ability of someone to look you in the eye as you're making a decision about giving yourself a raise, right? These become the standards that drive policy decisions around open meeting laws. Not that it was written for you, for this commission, because, we're primarily an advisory body. It was really written very broadly for, the 1,500 or so local government agencies that do actually have the authority to give themselves raises, and a history of not creating access, particularly for people for whom IT-driven strategies don't work. People who have disabilities or other challenges, which may include even being able to afford the IT access to, right? And so it's intended to have the benefit of the technology without losing the foundational element of public presence for important decisions. Having said that, there have been some conversations about whether or not the agreement that has been reached more recently has created the opportunities, because during the pandemic, online public bodies actually saw a dramatic increase in participation. And in fact, we had 120 or so people participating today versus the 4 people who came in person.
Yeah.
And so there are ongoing conversations about opportunities to continue to adjust those statutory requirements to get it right.
Yeah, it makes me wonder if maybe we adopt a corporate solution, which is you have hybrid, maybe if we can't get I'm in favor of keeping, 10 meetings a year because we do so much work, but maybe 4 of them are in person a year and the rest are Zoom, and then we're not passing anything, but we're at least meeting.
That's right. There are because the quorum rules really are about decision making. In fact,
so if we're not decision making, can't we still meet online and leave it open to the public and still have meetings?
And this is that's the system that Bagley King has allowed for committees, because our committees can meet remotely. You still have to have a physical presence, so that is never taken away.
Yeah.
But you can have folks remotely, and it would be more of a committee meeting, though.
But we effectively have that. If somebody doesn't show up and we don't have quorum, that's effectively what we have.
Yeah, and then
we're
you
just
can
making
just
it-
discuss that without taking any action.
Yeah, exactly. So,
Commissioner Danovich?
Yeah, thank you. Since I'm remote, I thought I'd propose that all the commissioners get a doubling of their salaries. Just kidding. A couple things. First, I do think that it makes really good sense to review our structure and governance before we dramatically increase the size of our commission, so that we're ready to accept and integrate that increased size as effectively as possible. I've seen over the course of my time on the commission kind of an evolution of how we practice, but I wonder if it might not make sense to have some kind of review of different commission structures to understand what our options are and what we should strive for. And I'll just leave it at that. I'm sure others, I certainly have some thoughts, on that, besides just kind of prioritization and delegation. The other thing I just want to raise is a question. We don't have to answer it right now because I was talking about it with Toby, and I don't know that we have an answer. But this whole change of name from mental to behavioral, understanding the meaning and the implication of that, and what it applies in different contexts, I think is going to be really important. From my perspective, those terms are synonyms. But I'm sure there are other perspectives, and so I want to understand what's in a name change and how to anticipate any implications that result from that.
Yes, thank you. Do you want to?
Thank you, Commissioner Danovich. We will do some homework on models that, and again, so as Kendra pointed out, we wanted to put the array of changes in Prop 1 that impact the Commission directly, have some initial conversation, get some direction, and then come back to you for action on items that require an action. We will explore models and bring those back, and The issue of whether or not behavioral health and mental health are synonyms has actually been raised during a budget hearing by members of the legislature, and we also will explore that and report back. I think our position is that we need clarity and consistency with the answer to that question, and we don't have that today. So we also will tackle that and report back. Thank you.
Please, Commissioner Chambers.
I don't want to drag this on, but I think it'd be great to talk about or explore what does that mean. But I know when we were working on the Psychiatric Advance Directives bill, there was an initial change that got struck out, but I mean, the bill is not active right now, but hope to have it again. But when there was a change from mental health to behavioral health to statute, legal counsel had analyzed, not from the state, outside, that it had significantly changed the law relative to advanced directives, and it could have potentially sent it down a whole spiral of impact and loss. So I am interested to see what is the meaning, and then also, I mean, and where are we getting the feedback on what this meaning means from? So making sure we have a diverse pool of people that can weigh in from different communities on what that means.
And Chair, if I could.
Thank you, Commissioner Chambers. Please, Commissioner Rolette.
That's a key point, Toby. I get to sit on too many of these committees and that talk about inclusiveness, and here's a place where it's easy to be more inclusive, and it just makes sense. I'll give you the commissioners a specific example. The care, the iterations around the name associated with care has changed because of feedback from the consumer and family community, and they influenced how it was presented and what the initial iterations of the CARE Act or CARE Court, as it was being described, what the implications were for that community. I would hope that we would certainly solicit the community of stakeholders around our name change and not underappreciate the implications associated with the moment. It seems like it's obvious to me that we would want to solicit some of their opinion, if not a lot of their opinion, about the name change, because, again, the stakeholders in the community say a lot about the appreciation of access of the commission and the commission's listening as it reflects a different experience that they have in other places where they feel that they're not listened to.
Thank you, Commissioner Rolette. Any other comments or questions at this time? Yep. Vice Chair Alvarez, and then Commissioner Carnevale, please.
Thank you, Chair Madrigal-Weiss. Building on Commissioner Rolette's comments, I'm curious the opportunity to maybe change up the structure a little bit. This also builds on Commissioner Danovich's suggestion. 27 people is a lot to manage. I completely understand that. And that's for our monthly all commissioner meetings. However, is there an opportunity to break up the work in buckets, whether it's, the Innovation Partnership Fund or early intervention or full service partnership, or I don't know what it would look like, but that would allow more opportunities for community engagement because it's broken up, and then B, not require 27 people to show up, right? That I think could lend itself to be more challenging. If that is the requirement for the monthly meetings. So, but I think what I want to make clear from like a high level perspective is what we opened up earlier on this conversation is there are so many unknowns with this process. And I think we should lean in to more engagement, particularly as we start this process. So to answer questions, to lift up challenges, as it moves forward. Maybe those work groups dissolve after a few years, but at least at the beginning, there's an opportunity to have more of that engagement, both with commissioners themselves as well as with community. And you may have already been thinking about all of this, but I'm just curious if that's something we could explore. And if it is, what then are the Bagley-Keene requirements for making that happen? Obviously, our committee structure right now requires staffing, 2 of us meeting. I mean, it's publicly available. If it's 5 members, like what sort of staff would be required of that? It has like implications, I recognize, from an operations perspective, and want to be respectful of that. But it does lend itself to the transparency and open dialogue that I think this commission is known for.
Thank you, Vice Chair. Commissioner Carnevale.
Yeah, thank you, Madam Chair. Just real quick on sort of the science of branding. You know, branding's a two-way street. It's important to understand what people think about the brand, but we can also be intentional about what we want the brand to be. So, for example, and I'm just using examples, on the one extreme you could say, well, we want them to think it's the same, and so we're just going to use OAC. We're going to emphasize OAC as our name, and it kind of signals nothing's changed. Or on the other hand, we could decide behavioral means that includes substance use disorder, and we start branding ourselves with that more as part of our brand, and that's going to signal to people what we're trying to accomplish. It doesn't replace how they think about it, but you can shape brand over time. So to some extent, I would encourage us to think about, we can't control what other people think, but we can control what we want the intentionality of our messaging to be. And I don't have a particular opinion about it, but it's a process thing.
Thank you, Commissioner Carnevale. And I just want to, in response to what Vice Chair Alvarez was saying, and I think some of the other comments made, just for my understanding, Sandra, in order for us to have a quorum, even if we had other subcommittees, for it to be considered a commission meeting, we still need a quorum of minimum 14 commissioners in person. That cannot change, and then that's considered a...
Correct. To have a official commission meeting, you have to have 50% plus 1 of your members. And the only vacancies count against it. So if, you don't get a pass if a seat is vacant, but you do lower it if you have people on leave. But yes, right now the math will be 14 in person to hold a commission meeting.
Thank you. And I know that since this became the new rules, there are times where we've had to wait hours where we were going to not have a quorum. I mean, the day before, and that's with 8. And so it's proven to be a challenge. So now to have 14, it's something that, we need to talk about considerations. So I appreciate, we do get a lot of business done in the 10 meetings. Now we're counting on more people to get it done in the 10 meetings. And so what if we had every other month? Maybe that's a model where we don't take votes and it becomes more informational. So I think where we're asking Toby and team to share with us what different models might look like. What could that look like? As far as name goes, I want to recognize that I appreciate the community engagement in ownership of the name and ideas. I think that is important. When we talk about, this has been one of the only commissions where we've really prided ourselves in being intentional with community engagement. I think that is important. I would offer that we have a couple of suggestions so that we don't start from scratch. Something, one of the things that we've talked about, maybe the California Behavioral Health Commission, because behavioral health is going to be the overriding. I mean, we're moving from mental health to behavioral health, and I agree, Commissioner Carnevale, that it is about messaging. And so, integrating substance use disorders and supports. So maybe we start with something and then ask our subcommittees. I think that's important. So if we don't have any more comments and questions, and that's an ask, I don't know if we do or not, please, Commissioner Robinson.
back to the concept of onboarding, going from our current numbers to a larger group. I mean, we might want to consider things like, should we have time limits on comments? Because if everybody talks and, I like my opinion too. But I think we need to think about some behavioral expectations that we set just to make the meeting manageable, but not to dissuade or cut off conversation and dialogue, but with that large of a group, the logistics of managing that become very, very difficult. So I think we need to consider, time limits and, really being deliberate about orienting people to how we conduct our business. So I think the onboarding piece should be, kind of a mandatory thing we set, and it should be very thoughtful about, setting a set of behavioral expectations. Thanks.
Thank you. So at this time, what I would like to do is ask for a volunteer commissioner to work with staff on some of these issues to help guide this process. We need to talk about the orientation and onboarding, to talk about the meetings and the pacings, and thank you, Commissioner Robinson. Thank you. That would be Commissioner Robinson, to make recommendations on the name and the role of the committees and delegated authority. So thank you, Commissioner Robinson. Then we will have Commissioner Robinson work with staff and team. What?
I was just trying to clarify, if you volunteered on number of meetings and pacing, the name, the delegation, the role of committees.
To work with staff, Commissioner Robinson. Yeah. I think it could be a couple of commissioners working with the staff to make some of these recommendations. Okay, orientation, how about meetings, pacing of meetings? And name, I think it could be.
Carnevale
name.
Just to clarify.
Yes, sir.
We have the authority to modify our name?
To clarify, in statute, you do not. But as Kendra pointed out, California has a 80-year-old entity called the Little Hoover Commission. We've probably all heard of the Little Hoover Commission. Its actual name is the Milton Marks Commission on California State Government Organization and Economy. About 60 years after it was known simply as Little Hoover, they added that in the statute. The first 5 commission is formally the California Children and Families First Commission. So the idea is we can adopt a nickname and then
DBA.
There you go. And you can actually, either incorporate that into the law or it's just common usage, right?
Okay. I will work with meetings, delegated authority, just because I can speak to that. Role of committees? Thank you, Commissioner Chambers. All right, thank you. I also want to recognize that we will need to elect a new chair prior to our change in membership. And I will happily work with whoever is elected chair later this year. We are looking at going for elections in the month of October. So then I will work closely with that person October, November, and December. And so I just wanted to, that's why it's important that we start these conversations now. And Kendra has outlined these exciting opportunities ahead of us, but we need to really work efficiently to leverage these changes. And we really want to welcome the new voices from our behavioral health system through maintaining an in-person quorum. It's going to be challenging. I think we talked about that and why. Delegated authority will help us with some of these routine matters, but we must anticipate potential obstacles with 27 commissioners. So I'd like to, already we are working with staff to kind of bring some of these things to our attention. So thank you for that. and just moving forward. So thank you for letting us have this conversation now and start these initial talks. And did you want to say something?
Yeah, if I could just
Please.
make a brief comment. In my experience with the commission, the members have always done a great job of leaving their roles behind and making this a group effort to meet the larger goals rather than lobbying for my job alike. And I think if we can help impart that culture to the new commissioners, be very purposeful in doing that. I think that will help a lot.
Absolutely.
And maybe we could have a team sort of work on onboarding people.
Absolutely. Thank you, Commissioner Gordon. So at this time, we are going to move on to public comment. At this time, members of the public may request to make a public comment on Agenda Item 9 by clicking the raise hand button on your computer or the app, or of calling in by pushing *9. Are there any public comments on Mariani? Please raise your hand now as the queue will be closing.
We do not have any comments in the room, and we have 3 virtual comments. The first comment we have is from Stacy. Your line's open.
Thank you. And Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. And I take my hat off to all of you, the commissioners and the staff, because yes, there's going to be a lot of big changes. I think most of the commissioners have done this already, but if you have not attended a California Behavioral Health Planning Council meeting, you should, because they have 32 members. And so they're actually already a larger body than you. And I don't know if Jenny Bayardo is still there, but because they have been in existence longer than you, I really think they have it down to a science. Now, again, I'm not suggesting you copy them or anything, but it's just the first time I attended one of their meetings, I was quite overwhelmed, and I was just a public member, and it was quite overwhelming. But they, again, you could see what works for them and what would and would not work, or what you would not like or like for you. They meet 4 times a year, but they meet for 3 days or even 3.5 days. So anyway, I do think they do a good job. They have committees, structured committees. And what I really like about them is that the public is welcome, and at the committees, the public has a lot of opportunity to have dialogue. But then at the meetings, of course, things have to be quite a bit more formal because, again, they have 32 members. I would also like Commissioner Robinson, thank you for volunteering, but I hope that you also consult with the public or the stakeholders somehow in some of this. I do think that we're here to support the commission, and because we would like you to be as efficient and also, though, as open and accessible to the public as possible. So I'm really hoping that there will be an opportunity for collaboration with stakeholders, not just reporting to us and saying, here's how it will be. And also, when you start redoing your rules and procedures, again, I hope that this is a transparent endeavor, and that there are many things that we feel very strongly about. Your current rules and procedures mandate that you have a CLCC and CFLC, and we don't want that to change, etc. Also, if you could put in there the definition of a committee versus a subcommittee. I know my time is up, so just please specify how these decisions will be made and what criteria. Thank you so much.
Thank you, Stacy.
Next, we have Steve. Your line's open.
Hi, can you hear me now?
We can hear you fine, Steve. Go ahead.
Thank you. I always need to check since I'm not online. I'm going to repeat a little bit of what Stacy said. I came on with, and I do believe first of all, I am a member of the Planning Council, and I've been so since some time now. And I speak only for myself. This is not anything official from them, but I do believe actually our actual numbers are not 32 but 40, because they include people assigned from the state, from just different departments, etc. And it's as she said, we usually meet it's like 3 days spread over 3.5 days, to put it simply. Most of our work is done in the committees. Now, our committees are not the same as your committees, made up entirely of people, or almost entirely of people from outside. Our committees are members of the Planning Council, and they're like permanent subcommittees or work groups. And most of the work we do is in those committees. And it's so well received that actually, unless it's something really stellar or startling, we do a report out, but mostly we make the decisions, and the full Planning Council does not need to verify as a whole what those decisions are. And although we can elevate if we want to, we have a general session that basically is a whole day in 2 parts. And I would suggest that you talk, because with some of those people, again, not suggesting as a perfect model, I think we could tweak it ourselves, but they're already handling 40 people, every 3 months or so. So, and we have in between meetings as well as needed. So just to put that before you and to suggest that as a resource. And speak with Jenny Bayardo. She has a lot of information on this stuff. So thanks, everybody. Bye-bye.
Thank you, Steve.
And our last public comment is from Jay. Your line is open.
Good afternoon, Commissioners. Jay Calcaño with the California Council of Community Behavioral Health Agencies, CBHA. So CBHA, again, we represent a diverse array of behavioral health providers and businesses. And as our organization's founder, Rusty Sellex, and members were the backbone of the inception of Prop 1 alongside Daryl Steinberg and other advocates when it was known as Prop 63. We're heavily invested in the Behavioral Health Services Act and its implementation. We just want the Commission to note that, especially in this tense environment of payment reform with CalAIM, Care Court, and other innovative efforts that are being brought forward by the governor and legislature, we're asking that as the Commission considers changes to its governance, that CBO stakeholders be included in every step of the way, echoing Stacey Hiramoto's comments. We fear that services that were once supported by Prop 1 in the past will no longer be, and thus we want to share that we are willing to work with the Commission and others to ensure that there is continuity of care for the communities that our members serve. So we thank you for your time, and I will pass it back.
Thank you, Jay. So Kendra, thank you for sharing your knowledge. We look forward to having you share more on the implementation efforts, and thank you. Commissioners, at this time, thank you for that working lunch. We are now 40 minutes ahead of schedule, because that's just how it goes. You want to keep going. I appreciate that. We have one speaker who is not yet here. So let's take just a 10-minute stretch break, and we will get started at exactly 2 o'clock, and we will still be ahead. So let's just give that speaker a few minutes to get here. So 10-minute stretch break. We will get started at 2 p.m. Thank you. We are now moving on to agenda item 10, where we will hear an update on efforts to draft a strategic plan for early psychosis intervention. At this time, I would like to invite Toby to get us started with this conversation.
Thank you, Madam Chair. And I want to introduce Kana Enomoto with McKinsey. Kana and her team, with support and guidance from international and national and certainly state and community experts here in California, have been supporting the Commission's work in response to the direction from the Commission that actually dates back several years, but more recently, direction you gave us to use a portion of some of the early psychosis funding we had received in the past to develop a strategic plan to scale these services. You have in front of you or we have distributed a 80-page draft that looks like this, and the team has passed out some handout materials. We decided to shrink the slides. Cody, if you can put up the slides. Kana is going to help with the slides because I am incapable of speaking and pushing a clicker at the same time. And I am honest about that. And recognizing that my performance review is coming up, I may hear about that at that time. For background, going back before I was hired by the Commission, which is about 10 years ago, the Commission funded an analysis of services that were available to consumers who were experiencing psychosis with the focus on early intervention. And we funded a research project led by Tara Needham at UC Davis, which documented that there was a profound lack of services for people with psychosis, services that were targeted or that were specialized in focusing on early psychosis intervention. And the services that were available varied in the quality, the intensity, or the fidelity to the model. In response to that, the Commission authorized funding to draft an innovation plan to scale evidence-based care based on a national model called Coordinated Specialty Care, which we'll talk a little bit more about in a second. And so we funded the drafting of an innovation plan. That work was led by Dr. Needham at Davis in partnership with the then Mental Health Services Act coordinator from Solano County, Tracy Lacey. And Solano really took the lead, Tracy really took the lead, and introduced the opportunity to other counties. And that led to one of the Commission's first learning collaboratives, the first area where we facilitated multi-county investment in an opportunity to jointly spend innovation funds and to learn from each other as counties began to tackle shared challenges. At that time, then Commissioner and Senator Jim Bell sponsored legislation to allocate, I believe it was $15 million, to further extend investment in evidence-based practices. And over time, the Commission used more of its resources to support this effort. And as was mentioned in public comments earlier this morning, as part of the discussions with the administration around the implementation of the Child and Youth Behavioral Health Initiative, as they identified opportunities in the funding rounds for early intervention, we challenged and encouraged them to ensure that a portion of those funds were available to support early intervention on psychosis, building even further on the foundation that we had established in partnership with county behavioral health directors and other providers. And we have then worked with the Department of Healthcare Services to help shape how the state uses a SAMHSA block grant set aside that is supposed to be that is required to be dedicated towards early psychosis. And we have been working with partners at Kaiser to understand the economics and the drivers of costs associated with how commercial insurers and commercial providers address psychosis. As we did all of that, we recognized that the evidence from Dr. Needham's work suggested that we were really only responding to about 10% of the need in California. And we were hearing anecdotally from our partners at the Department of State Hospital that the largest concentration of clients that are coming in through their doors through a felony charge, felony criminal charge that resulted in a designation of as incompetent to stand trial, that the majority of those cases were individuals who were struggling with psychosis and did not have access to effective interventions early in the course of their illness. And recall that during our visit, the Department of State Hospitals discussed how these slots can be more than $300,000 a year. So that pushed us to recognize that if we're going to be able to improve outcomes, if we're going to be able to reduce justice involvement, certainly the population of Californians who are struggling with housing that often most challenge the public are folks who are actively in psychosis, right? Yes, we have very difficult challenges around housing affordability, but if we address the affordability and we don't address effective care and support for people with psychosis, we will continue to have challenges in terms of people who are unhoused. So this pushed us to ask questions about how fast and how can we scale access to care, recognizing that our funding strategies, as they were at the time and continue to be today, really allow us to maybe grow coordinated specialty care, these specialty programs, 2 or 3 a year, when we probably need 200 or 300. And so we came to you and asked that we be able to use a balance of funds that the legislature had given us, left over from the money that Senator Bell had secured, to draft a strategic plan to scale psychosis. And so we did a competitive procurement, and McKinsey has joined us to really do 3 things. One is to document the landscape today as effectively as we can with the literature that we have. 2 is to do the math in terms of what we're spending today, what it would cost if we were able to scale coordinated specialty care as a best practice to at least 90% of the need, and what would the fiscal impact be if we were able to do that in terms of cost avoidance or cost savings. And the third piece, in my mind, the most influential piece, but also the most difficult, is to draft a strategic plan that identified the core elements that would be necessary to actually operationalize that, to get to that 90%, and the steps, the components that are necessary to be successful, including funding, but beyond funding, because as we've talked about today, workforce, public awareness, quality, access, integration with our system, certainly addressing issues around equity and disparities. So in preparation for today's meeting, we have a draft. It is clearly a draft, lots of work to do, lots of engagement. We have engaged peers and family members. We've engaged commercial insurers, legislative staff, partners in other state agencies, experts from around the country, and in some cases from other countries. But it has not been broadly distributed, in part because we were really focused on getting the math right. We wanted to make sure that the technical piece, in terms of how we make the argument, which is so essential for implementing the strategic plan, we wanted to make sure that we could begin a community consultation process with a foundation that was focused. And so beginning with releasing this as part of this meeting, we're initiating a process that will take a few months to actually share this broadly, do public engagement, work with our committees, work with our advocacy groups. I mentioned when I introduced our 2 teenage behavioral health fellows that they're reading the report, and I mentioned, I didn't name the work group specifically, but nothing like teenagers, to be honest, about the quality of the writing. And so given that the access piece, given that the ages that we're talking about, in which the vast majority of people who develop psychosis, it's really in these late teen, early 20 ages, we want to make sure that the strategic approach that we're talking about reflects the perspective of the young people who are the target of ensuring that our awareness, our understanding, our peer, our school-based, our workforce-based, our access strategies and awareness strategies overall really are beginning with the demographic that we're concerned about. So with that, this is why I can't push a button. Okay, so we are, go back. So in this sort of, iteration, here's where we are. We've done some consultation with subject matter experts. We have a long way to go. We are engaging the Health and Human Services Agency, the Department of Healthcare Services, the Department of State Hospital, the Department of Managed Healthcare, CalPERS as a large funder of services, and others. And so this is the stage we're at in terms of rolling this out. Any questions at this point? Perfect. Very quickly here, as we look at this understanding of psychosis, as a non-clinician, what I think about is, psychosis is really a reflection of, the most challenging behavioral health conditions that an individual and a family can face and a community. And so there's, wide-ranging individual experience, but it has come to represent, an early intervention comes to represent the best opportunity for us to engage and support recovery. As the slide says, 15 to 25 years old is where the greatest likelihood of developing psychosis, and it can signal other challenges in an individual's life. Connor might please if there's some element here that I'm going over, but we really think about it in terms of how untreated psychosis can impact healthcare, employment, housing, criminal justice, and caregiving. And the research suggests that when we respond effectively, we do a very good job of reducing the negative impacts of psychosis, including improving housing outcomes, dramatic reduction in criminal justice involvement. There's a really interesting tension between the reality that people can effectively manage psychosis and schizophrenia and have productive, healthy, and very meaningful lives, and a common perception that a diagnosis of psychosis is a sort of the end of a meaningful life, right? In our partnership with UC Davis, Dr. Needham talks about family members who come in and share that they wish their child had cancer instead of psychosis, because at least with cancer, I would know what that path looked like, and I would have hope. And in reality, the research demonstrates that effective supportive care, and I'll share with you that much of this project began with some early conversations with Brandon Staglin, with Ellen Sachs, with folks from the Resiliency Network. There are many among us who ourselves or our family members include people who are caring, able to effectively manage their needs. And when we intervene matters in profound ways. We've got some data, some of it's in the handouts, but just in the interest of time. So the model is part of the core opportunity and the challenge. So if we go back to about 10 or 15 years ago, I think it was 2012, the National Institute for Mental Health sponsored research that looked at a coordinated system of care, or CSC, that when we engage the individual and their family or whatever that support network is early and effectively, and we surround them with supports that include traditional medication and therapy, but also peer and family support, supported employment, community outreach, that we have a dramatic improvement in outcomes in comparison to what is often called typical care. We don't actually have necessarily a consistent definition of what's missing, but the research showed, and it was that highly effective, and as you can see, reduction in inpatient days, improved employment outcomes, improved educational outcomes, housing consistency, and less criminal justice involvement. And this research actually looked at people where there was an intervention within the first 18 months of their first psychotic break. And so the research has begun to define the standard of care, although there's recognition that the research was limited, and it doesn't mean that if we intervene after 18 months, that coordinated specialty care cannot be an effective or a more effective intervention. And it's also, because it was a research protocol, there were some age constraints there, so there's some tensions in the field between sort of who should be served under that model based on the research versus whether or not the model applies outside the bounds of the research. And there's also some tension over whether or not we should begin to engage upon a first episode of psychosis, or if we should engage through an upstream strategy, typically referred to as clinical high risk. And so these are normal and natural tensions in the space, but we want to put those out there. All right, next slide. So this reflects some of the work. I jumped the gun and I told you the story before we got to the slide. So here's the slide that is showing some of the early work. And this slide highlights full service partnerships. We've shared with you that we see early psychosis intervention as an essential opportunity, sort of the most essential opportunity for early intervention. And we recognize that full service partnerships are a safety net system for people who need that higher level of care. And while the Commission has been working diligently to strengthen full service partnerships, we want to recognize that effective deployment of coordinated specialty care strategies actually can reduce demand on full service partnerships. We're working even further upstream with our youth drop-in strategy and our school mental health strategy, particularly in terms of if we recognize that late teen, early 20 age range, that the schools are an essential partner in understanding what's happening in the life and mind of a young person who may be in a clinical high-risk situation or a first episode of psychosis. We're not envisioning that schools are providers to that level of care, but that schools are partners in awareness and access. And so, this timeline really shows the conversation in terms of connecting full-service partnerships, but also this, broader strategy around prevention and early intervention. All right, and so, Kana still has me in charge of the slides. So, as I said earlier, the best available research suggests that only about 1 in 10 Californians are getting effective care. And, I want to sort of express some personal outrage here. We just do not let that happen when it comes to other areas of healthcare. It is unacceptable, and there are, public consequences when that's the case. If 9 out of 10 people about to deliver a baby were doing so in the parking lot rather than in a labor and delivery center, the world would be a different place. And stigma, lack of awareness, lack of understanding, we have a long way to go. I think the research is about 25,000 Californians a year will develop psychosis, and new cases of psychosis. And so we're not talking about millions of people, we're not talking about hundreds of thousands of people every year, but we are talking about somewhere in the range of 20,000 Californians every year who develop a incredibly challenging illness that is very manageable and can be supported very effectively, for which their illness is not being supported. All right, so if I've gone gotten you energized and engaged. That was my goal. And
Good afternoon. Thank you all for inviting us here to have this conversation today. This is certainly a topic about which I am extremely passionate. And it was very fortunate for my collaborator, Erica Coe, and I. We met with Toby last year at the UN General Assembly, and he was very fired up on this topic and talked about how the Commission had been trying to lead work here, that he was wondering what was happening on the national level, and that conversation actually spurred us to engage in developing a national model. So this was built with NAMI, with National Council for Mental Wellbeing, National Association of State Mental Health Program Directors, and Toby representing the Commission, along with many of the leading experts in the world from NIMH, from Columbia, from Davis, et cetera, who advised us on how do we calculate the both economic and social costs and benefits of early psychosis and making this intervention available. So we actually partnered with the 5 organizations to build a national model through the McKinsey Health Institute, which is where I am. It's a non-revenue generating entity within McKinsey. And I'm the director of brain health, and we focus specifically on sort of underfunded, under-researched areas of healthcare. And we identified in that process about $167 billion over 10 years that would be gained for the United States. And our model was slightly different because we started with an estimate of 25% of people have access currently to coordinated specialty care, and also with the goal of getting to 90% access. So that national model is not here, but what I'm going to talk to you about is how we made that leap over to California, because Toby had the idea after this conversation saying, like, we need to bring this to California and use these kinds of analyses and make this economic case so that California can once again surge ahead of the rest of the pack and lean into this problem. So what we found in looking at the literature, I will say this is, we took a relatively conservative approach. The literature looked primarily at emergency department utilization, psychiatric inpatient stays, arrests and incarceration, and homelessness. We do not have a lot, and employment and education outcomes. We don't have a lot that's further downstream looking at things like state hospitals. And so I would say that these numbers, you take them with the assumption that they're actually fairly conservative. There's probably even more kind of non-quantifiable or even quantifiable benefit from coordinated specialty care, but the research just hasn't gone there yet. So we only use things for which there was a documented evidence base. And what we found in the model was that you could, that with an investment over the course of 10 years, you would actually be where you were strategically trying to reach 90% of the affected population. You would actually be able to reach about 135,000 more individuals while saving the state, saving families, saving individuals, saving employers $12 billion. And the investment we calculate the investment actually turns revenue neutral or cost neutral in year 3. But we've highlighted here what would happen in year 5, where you have about 17,000 individuals getting access in that year, which is 9 times the number, 17,000, which is 9 times the number who are getting it currently. You're saving about $0.9 billion in direct healthcare costs and shifting those costs from serving 9 times more people from emergency departments and psychiatric hospitals to outpatient care and care in the community. So it's not only more efficient use of resources, but one that yields better outcomes for people. And we're saving about $1.7 billion in annual non-healthcare cost savings. So that includes the aversion, that you avert lost income, you avert people going on Social Security disability, and you avert people, like caregivers, family members, from missing work or presenteeism or absenteeism or needing to leave the workforce entirely in order to dedicate more time to caregiving. And so in total, you get about $860 million in annual net savings, with $2.4 billion in direct annual cost and $3.3 billion in direct and indirect savings. So you treat, you can reach, you can help 9 times as many people, 9 times as many families, and you're saving almost $1 billion a year while you're doing that. So that is where we start with the good news first and the big picture first, and that is the biggest takeaway from the model. Here's a little bit more detail. So Toby said they brought us in so we could do the math. We did do a lot of math. This is just the tip of the iceberg, and it's quite simplified. But for those of you who want to dig into the report and dig into the presentation deck handout, there's much more where this came from. But what we did when we looked at this model, we looked at not only, it's not just people getting CSE and then leaving. What we defined it as people getting coordinated specialty care within the first year or two of their initial onset of psychosis. We do know that there are some programs that take people, from year 3, 4, and 5. And of course, the program can be effective for those individuals, but the greatest cost savings are when you get people very early on, first 6 months, first 12 months. And so there's research that people who come in later can still benefit, but they tend to still generate higher healthcare costs. So the preventive nature of that early intervention is very important. So here we highlight the growing number of people over time who are in coordinated specialty care at any given year. People are in the program for about 2 years. And then we're assuming that people are moving into a robust community-based wraparound ongoing care. So they're not transitioning from CSC to nothing, but CSC to something that's also robust and evidence-based. And so this is, again, a very conservative model because we are projecting out that we're delivering the standard of care to everyone over time. And so that's where you see the net benefit. The group that is the delayed access, so people who are coming in after the initial period, can still benefit, but they continue to cost more. And so the more we can reduce the delayed access group, which means increasing the capability of schools, of hospitals, of law enforcement, and other systems to recognize psychosis. I was in San Diego and heard the story of a young man where the school had been trained with mental health first aid and prodrome and early psychosis, and a 13-year-old young man brought a knife to school. 13-year-old young man, family was undocumented, parents didn't speak English, and he brought a knife to school, and the teachers took the time to ask him, "Why did you bring a knife to school?" And he said, "Because there's voices in my head telling me that someone's trying to hurt me." Right? And so instead of that young man going to calling law enforcement, going to juvenile detention, and starting a completely different path, they brought him into a early psychosis program. Brought his family in to help them understand, how do you help manage this condition? What does this mean? What are the things that you can do? Connected them with other Spanish-speaking families who are managing the same thing, right? And you can just imagine the trajectory of that young man completely changed. Stayed in high school, graduated high school, got a job, and it could have been so much worse. And so this is the importance, and it is really a team sport. Right? Coordinated specialty care becomes a team sport. You can see there's healthcare, there's caregiving, there's employment and criminal justice implications that we have captured. But just even from that one illustration, you can imagine that there are so many other implications. There's child welfare, there's state hospitals, there's community, health and cohesion that are also important. So here we show the breakdown even further of the different categories. So the primary savings is in healthcare. where you have costs and increased expenditures, but also savings when you go into the 90% access group. Considerable amount of savings comes from caregiving. So it's somewhat of a economically controversial concept, where how do you really quantify that? But there's been a lot of research in this space, and I think many economists that we talk to are moving more to household calculations of net benefit from health interventions, and so I think this is very appropriate that we have done this way. But you see that you actually don't save a lot in criminal justice from these models, only because generally we're talking about very young people. And so their costs initially, right, at this age of their lives is relatively low. It is later on when the chronicity, right, and the homelessness and everything else comes into play that you see much more costs building up. But you do see, important gains in employment and in criminal justice and housing as well.
All right.
Or should we pause if there's any questions?
Yeah. So questions on the math. I think we've had lots of conversations with our community and programmatic and research partners around the impact of the math in terms of our ability to shape and guide investments and opportunities, in addition to the human story of the young person in San Diego, right? And unfortunately, we have many more stories of where there wasn't an intervention until someone landed at a state hospital with a felony charge, right? And to remind those of you who did participate in the site visit to Napa, some of those folks are there for 2 or 3 years. Some of those folks are there for 30 or 40 years, and so I just want to pause and see if there's questions about the math so far. That's the more complicated piece in terms of recognizing that it is conservative, that it doesn't pick up the potential savings in those areas where we actually don't have good research. Commissioner Robinson, if I may, Madam Chair.
Yeah. Not a question about the math, maybe the message of the math. There'll be people who say, this is cost avoidance. This is not, is this really true savings? Am I going to be able to not hire somebody or decrease staffing or, so how can we message this in a way that heads off what I know will be skeptics at the pass? Because I've seen presentations like this and people say, oh, well, that's just cost avoidance. That's not really true savings. Sure. What are your thoughts about that?
Two real-world examples. State of California increased funding for the Department of State Hospitals about 2 years ago by, I think, $1.2 billion. So if we can avoid that cost that this isn't the avoidance of future potential costs. This is actual cost avoidance that results in savings, heavily dependent on how we implement it, right? The other example is we do not yet have this for presentation to the full commission, but we invested a very small amount of money to support a research project with Kaiser Health System, which, sir, you may be familiar with. They tracked, Commissioner Robinson's from Kaiser, they tracked about 60 clients who are receiving services under Kaiser through partnership with a program that Commissioner Bontrager knows well, the Aldea Family Services. About 60 clients getting coordinated specialty care versus, in comparison to 60 clients were getting typical care, and within 6 months they saw a dramatic reduction in direct costs associated with ER utilization. And so in addition to doing this, more economic analysis and projections, we've actually been working with key leaders in positions where we think the demand for this is very explicit and clear, which is part of the reason why we have been engaging the Department of State Hospitals as a partner to review this work and engage us, because in those conversations we're asking, what do you need to see in the analysis to lean in and make the investment in the strategy pay off?
We just add
Okay.
to that, we do show the literature would also say there's an average reduction in healthcare expenditure from about 61,000 per person to 44,000. So it is a sort of a concrete savings of math. You have to also, I mean, it's not that there aren't investments that also have to be made, but it is real world dollars in pockets.
Thank you. So I'll take the over-under bet on the other side of Commissioner Robinson. And so I'm wondering, as a venture capitalist who tends to be more visionary, why are we stopping at 10 years? I mean, I presume we have reasonable cost estimates of what it costs over the lifetime of a care of somebody who's psychotic and is not treated. So why aren't we considering, or showing both at least? Why do we take this over, what I would call overly conservative estimate? Because I worry people go, oh, well, it's Sacramento's like, oh, $12 billion is a rounding error. We'll just let people suffer and keep spending the money. I mean, why are we not getting people's attention with a bigger headline here?
I mean, I would say we are trying to be robustly evidence-based, and so definitely appreciate the sentiment of thinking bigger, thinking longer. There haven't been those kinds of longitudinal CSC studies that have followed people over the course of 20 years where we could necessarily see that. What we have seen, and we were also conservative in terms of like not necessarily adding in the value of a statistical life, but we know that within their first year of experiencing psychosis, people have an 8x rate of suicide, right? Death by suicide goes way up when people find out that they have a psychotic condition. And could do that. I think it's how daring the commission wants to be. And on the other hand, there's one question would be like, why do we need to do that? We're serving 9 times more people. We're serving 135,000 young people whose lives will be completely transformed by this type of intervention. I don't know how much we talk about how much heart transplants or kidney transplants save. They're not necessarily a ton of ROI on.
They're a profit generator. What do you mean?
Yeah. So I sometimes take umbrage that we have to actually even demonstrate the ROI on actually delivering the standard of care to people who are in great need.
We do have system costs. I get that maybe there's not a longevity study around individual, but we do know the system cost that's supporting these people. So I would just push back and say, I don't get why we couldn't make some estimate around that, even if it's more speculative. You know, we could use some cautionary language about
it. As we'll discuss in this next phase of this presentation, and I think as you saw in the site visit that you facilitated at UC Berkeley, is the models, the culture that asks for those models, and the sort of the risk calculations that people are looking for and willing to take that so clearly are robust and persistent in cancer and in aging and other areas of healthcare really have not been applied to the behavioral health section the same way. And so it's a bit of a calculus of what is responsive to the community, and the community of policymakers and decision makers in the behavioral health space aren't quite acclimated to the timelines that you're looking for. I believe the 10 years is based on standards that coming out of the Congressional Budget Office in terms of what's sort of standard practice. And because we're really talking about a governmental strategy here, we've sort of adhered to the governmental culture. You know, I would say the umbrage comment is, how many more stories do you want to hear about a 13-year-old who brings a knife to school because they're behaving rationally and normally and taking very good care of themselves in their minds because they're being told that they need to bring, they're hearing this, right? The good news is we can actually elevate the opportunities in that space a lot easier, and those alone should be enough.
So maybe, and that makes sense. On the other hand, we could couch it and say, in order to elevate this disparity between behavioral health and the rest of the healthcare system, you could say something like, if we were calculating this the way we calculate cancer, then it would look like X, and you accomplish both objectives at once. And so, I mean, there are legislators who are not in the behavioral health system, I presume, that, will participate in decisions. So I would just like it, I would love to see it couched for both populations, I guess is what I was thinking. But I trust you more than me on these matters.
Yeah, I think though the other message in the example you gave is that we vastly expanded the surveillance of young people to detect these potential problems before they occur, and basically that's free. Number one, in the case of they probably had the training, teachers had the training. That sometimes is a problem because a lot of times teachers have enough to do and all of that. In the model we're using here in Sacramento, we're putting a mental health clinician in the school, so there is a trusted source to validate that direction in diagnosis, and so I think making sure that there's broader surveillance of our kids in as many ways as we can create is hugely impactful. And the same would be true of young kids now that we have TK in kindergarten. That would be 4-year-olds, 5-year-olds. If you have somebody out in the community, you could work with preschools, childcare centers.
Yeah, I was going to wait till later on this, but since Commissioner Gordon mentioned it, I think the piece that's missing, or maybe you save it for later in the report, is where our innovation intersects this. We now know from Berkeley, from UCSF, our ability not just to catch it at the cancer at stage 1 or stage 3, but catch it, before it forms, and our ability to test 3 and 4 and 5-year-olds who may be at risk way before, the numbers you're using. Again, I wouldn't put it in an economic model, but I would love a section on innovation that captures additional upside and programs we should be investing in.
Go ahead,
Can I add
please.
to that? I think unlike what Commissioner Carnevale is saying is, I think where there's a market failure, government steps in, and government has paid more of their share of the costs of these interventions than the private sector, whereas commercial plans will pay for cancer treatment. Coordinated specialty care, EPR, FEP, whatever you want to refer to it as, is not an essential benefit. It should be. Because otherwise folks fail, and then they wind up in the Medi-Cal system, and Medi-Cal, or us, the public, bears that burden more so than the private plan or the commercial plan. So I think when we look at an analysis, we have to look at, are we fairly sharing these costs? Can we impose a little more obligations on the commercial world to cover this? And there's examples where recently the state of California has done that with the new multi-payer fee schedule at schools, compelling commercial plans to cover certain mental health services provided at schools. So there is precedent for this, but we certainly need to look at not just the cost avoidance, but who bears those costs. Commercial or the private sector should not be exempt from bearing the costs of these services.
I just want to make comment to the story in San Diego County and focusing a lot on changing the paradigm in our schools, that it's not just to, where I appreciate what Sacramento is doing, and I know many of our schools are doing that, but it's the teachers who recognized it. So we don't have to wait to get to the specialist who's a counselor or a mental health professional. 5 years ago, the teachers would send that child right to the principal. It'd be a disciplinary act, and nobody would have asked what prompted that. It would have been, you're suspended or expelled. So the fact that we now have teachers pausing, asking the question, it's just, I applaud that. I'm over the moon with that response. So thank you for sharing that story. And I know you have a phase 2 to this. So
Yeah, so, and I want to just respond to Commissioner Bontrager so he isn't allowed to leave the room.
Can't go anywhere.
So there's really sort of three-pronged strategy on the commercial insurance. One is the essential benefit parity sort of regulatory argument, right? And we're talking with the governor in the legislature about that strategy, consistent with the positions the commission has taken in the past. The Kaiser work was to see if there was an internal economic incentive for them to volunteer coordinated specialty care. And we're now talking with them about whether or not their own research was robust enough to change the actuarial models that drive their decisions around making this, the default practice. And the third piece is engaging with CalPERS to simply say to the insurance marketplace, if you're going to play in the marketplace with us, you will have a coordinated specialty care benefit. And so all of those conversations are underway, consistent with your comments. So thank you, sir.
I support any lever you want to push because we need to push all of them.
That's right.
Yeah.
So moving on to the slide here, we spent a lot of time thinking through what it would take to get to 90%. And we tried to develop a conceptual model that built upon the conversations we've been having over the course of the last 10 years, really, in full service partnerships and school mental health, and recognizing that we need a strong North Star, that vision. Equity needs to guide everything we do. This work has to sit within an ecosystem of other services, public awareness, 988, all of those other services. But there really are sort of 7 foundational elements in addition to vision, equity, and system that start with the key goals of broad and compelling public awareness that is both about what psychosis is, what it means, and what should happen if that is something that is happening in my life or the life of someone around me. But it's also public awareness so that we have a public accountability strategy that is really driving decisions to ensure that we're making progress towards the desired goal. Access. And, consistent with comments, that access needs to be independent of who you are, where you live, your language, your race, your culture, right, and which medical or payment system you're in. And quality is not a static standard, but it is a dynamic investment in learning and improving, as we see in so many areas of healthcare today, as evidenced by the site visit at Berkeley, but is still a bit out of reach in our space. And these 4 foundational levers, funding, workforce, a data and accountability system that is informing awareness, access, and quality, of course, and then the infrastructure for success, which is sort of this catch-all term for us, but it's really referring to some of the electronic health systems, it's payment systems, it's all of the ways in which these things work together. And we built this with the understanding that as we improve upon it through the public engagement and community consultation process, that if this actually becomes a useful conceptual tool, is this a conceptual tool we can use for other areas of our work or other people's work, such as full service partnerships, such as school mental health, crisis services, and so forth. And so this became a very helpful framing of what is necessary to get from 10% to 90%. And again, it's a draft, and so we're really looking for guidance. Go ahead and go to the next slide. And so this is not the one that I was expecting. So, well, it's okay. So what we're I think you get the message, right, is that this is a draft. What we're trying to do is create this conversation and create public understanding and awareness of the challenge, the need, and the strategy that is going to be necessary in order to get from that 10% to 90%, we fully recognize that achieving the kind of fiscal impacts that we're projecting based on the literature is really going to be driven by how this would be implemented, right? And this really does build upon the key themes or priorities that this commission has been focused on, which is broad public understanding, public engagement, an aggressive population-based strategy, right? So many of our conversations historically have focused on what county behavioral health departments are doing. We want to recognize that they have very limited capacity to finance these services given the revenue streams that they receive. And so we want to understand how we can create a financial strategy that doesn't depend on the discretionary decisions of county supervisors based on MHSA revenues, right? This is, we're looking for something actually much broader than that, leveraging not just commercial insurance. And one of the questions we're asking ourselves is, would it actually be cheaper for the state of California to pay the non-federal share of Medi-Cal, which delinks expansion of services from county coffers, recognizing that the state is paying a premium through state hospitals, through education costs, through workforce challenges, through so many of the other systems. Would it make sense to actually rethink how we finance not all of behavioral health, but this particular essential node in a crisis or in a early intervention continuum of care? So this is very consistent with all of the work that you have done, all of the values that you've expressed over the years. And what we're really trying to do is, get to this issue of measurable and specific goals that could then allow us to operationalize policy strategy, workforce strategy, and some of the questions that we're asking of our partners in state government is, as the state begins to roll out Prop 1, because we are in this planning phase, and there are new resources coming to the state for prevention, for early intervention, for workforce, for innovation through this commission, is this an opportunity that we should be putting a little more attention to than we might otherwise? This one's mine. Okay, so really, we're moving this forward will be challenging in terms of all of the pieces that are necessary. Important to connect with the Department of Healthcare Services and the Health and Human Services Agency, and again, managed care. Some of our little more non-traditional partners like CalPERS, right, where we see a tremendous potential to work with them and recognize the role that they have in ensuring that public employees, certainly if we could do this in partnership with CalSTRS as well, our teachers' retirement system, we believe there's an opportunity there because there's such a large player in the insurance marketplace, but also the public sector carries such a heavy burden of the cost of inadequate access to care. And so a lot more conversations to happen there, building out a change management plan, a performance management plan, and a communication strategy. We have a lot of work to do, but this is where we are in terms of this particular proposal. Is this one me? Is this one you? It's on me. It's all me. Okay. All right. So we have not finalized our thinking on this at all because we have really just begun the process of sharing and engaging diverse communities and voices. But the idea is that we will bring this back to you. We're going to spend at least a couple of months sharing this more broadly, doing some focused engagement, having focused discussions, and as we refine the conceptual framework, the narratives, right, as we begin to understand better the challenges that are in front of us, the kinds of partners who have suggested signing on to further this conversation. The goal would be to turn this into an implementation plan over time. Some of the challenges that that we've put in front of us are: is this something that the commission should do versus something the administration should do, right? And how can we help them, or how can we partner with them? As you heard from Stephanie Welch earlier today, that they recognize their own capacities, strengths and limitations, and they also recognize ours. Commissioner Carnevale and I have had a number of conversations about how this actually might be a really interesting early opportunity for a public-private partnership through the innovation work that the Commission is supporting. Questions?
Just a quick one. If we were, how many counties would you guess might be out there interested in engaging in a first pilot? Are any of them expressing interest, or, have you had conversations?
So I think I'm going to cue Tom here to tell me to go up or down. I think we're actually working with about 9 counties now to develop coordinated specialty care systems. So those early investments resulted in the launch of new programs, the development of a center of excellence at UC Davis to provide technical assistance, a system for consistent data, consistent gathering, to gather, to analyze, and return the data to our partners, and the infrastructure for collaborative learning across that 9 counties, which including a hub and spoke model supported by UC Davis. The bottom line is this approach of $20 million in grants every 2 years won't work, in large part because the financing doesn't match the model, both in terms of what Medi-Cal will pay for. So they'll pay for about 80% of the components of coordinated specialty care. Commercial insurance falls further behind that, and that even Medi-Cal requires the counties to use their MHSA funds to draw down the federal money. And so it is not even clear that we can sustain the programs we have today under the financing model, the workforce model, right? And it's not clear that we're persisting as assertively as we need to in terms of both fidelity to what we know today and the capacity to learn today to shape the work we're doing tomorrow, because of the way fiscal and accountability and other incentives are structured, just to draw it into accountability.
Which is where the capital innovation could really come in.
That's right.
With public-private, because one way to look at this is the way you've showed it, which is a rolling waterfall. But the other way is to say, if you fix this all in one day, it would basically be a one-time investment to go from 10% to 90%, and that is a specific cost. And if you infuse the system with that money, you could rapidly get this. You probably, as a practical matter, you wouldn't, because there are operational issues. But from a modeling standpoint, there's a specific number to change that dynamic, and that's where I think a public-private partnership could get very interested, and that there would be a return of some kind that would attract them.
I think my presumption here, and it may be inaccurate, is if we fix the financing system, then we can do that. But in the absence of an alignment between a reliable revenue stream, we're transacting on the goodwill of counties to basically tap into limited discretionary dollars. And again, that's the way we've designed this system, and that's why we have the system we have.
And a reminder that 2/3 of people, or at least 50% of young people, have commercial insurance. And so you're talking about reaching beyond the state systems, and doing the math, you need at least 200 more CSC programs around the state. And so doing that also probably would benefit from some de-risking, but also a lot of partnerships.
But my understanding is when they reach that point where they want serious services, they move to the public sector anyway. So wouldn't they really want to, if you actually were penetrating that population, wouldn't they all move to be uninsured anyway?
I think the goal, though, is to keep kids, keep young people
Yeah, I'm not saying
in
that's the
school,
goal.
keep them working,
Yeah.
and that this becomes a condition like many other,
Yeah.
childhood health conditions that can be well managed
Yeah.
without having to leave your
Right.
current status.
Yeah, understand.
But currently, right, that is something that people would do because we can't access CSC programs when you have commercial insurance, and so
Yeah, I was thinking of just from an economic modeling viewpoint, not to say, well, half you can lop it off, you can divide by 2 because they're covered. Well, they're not going to be covered if you got to that point in today's system.
So just to be clear, we're not asking you to adopt this report. It's not ready. It is ready to share. It's ready to get feedback. And, I would be more than happy to answer any questions today or to sit down with you and read. As I look across the commission's membership, this touches every one of you. And you bring a level of expertise that we need to make sure is infused into this work. And so, please, either today or after this meeting, share your concerns and your thoughts and help us figure out how we can move this from a strong conceptual paper into an operational strategy that will shape policy and practice moving forward. And there's actually a bill moving forward in the legislature to ask us to deliver this, and so we're talking with the governor's office, and so we think that the timing is right. Thank you for the chance to put this in front of you, and happy to answer any questions and to continue the conversation, and we hope to be back in probably November, maybe earlier, with a final.
Thank you, Toby. Thank you, Kana. And at this time, we are going to invite members of the public, may request to public comment on agenda item 10 by clicking the raise hand button on your computer or the app, or if calling in by phone, pushing *9. Mariani, open the lines, please, and do we have any public comment either in the room or online?
We have one public comment in the room from Kit.
Push that button there, Kit, on the front. Yeah.
Thank you. Okay. Kit Wall, and I will say I'm with Words to Deeds today because you were talking criminal justice, so why not? But back in the math question, in one of my former lives, I also worked for Eli Lilly and Company. And so in listening to the math pieces, and it's probably in, Kana, this is probably, your world, but I'm thinking, a lot of the work that we did, I was in government relations and I had different projects, but was two things. Was the economic model, trying to think in advance when a treatment was released, what was the economic argument for whether or not it was going to work or be advantageous. And so I'm wondering if any of the biotech, pharma, any of that industry, any of the modeling that they're doing is part of some of the modeling that you all have considered or is folded into some of that. You don't necessarily have to answer that question. I was just thinking about it. And the other one I was thinking in the math section was the speed to diagnosis or accurate diagnosis. Was that also factored in? So those are my questions.
Thank you, Kit.
We also had one public comment online from Jay. Your line's open.
Hi, Commissioners, again. My name is Jay. I'm with CBHA, and just wanted to note that we appreciate our inclusion in being as a stakeholder in the process for feedback with this early psychosis strategic plan draft. We look forward to hearing the feedback from the greater community and from the commissioners. And just want to state that we value early intervention approaches like this. One request that we do have for the commission to consider is the thin but important lines between primary, secondary, and tertiary prevention, and then the various culturally specific modalities that can be lifted up to support diverse communities. We see this as an opportunity to highlight the most impactful interventions across our state that can serve the diverse needs of many different populations that live in our state. And I will pass it back.
Thank you, Jay. So as Toby mentioned, just to be clear, we're not envisioning, well, we did not adopt this report. So we are going to make sure that we have plenty of opportunity for additional feedback. Definitely want to hear back from our community. So we will discover ways to make sure that we open opportunities for that as well. So at this time, there were no other public comments. Is that correct, Amariani? I saw no other online.
Yes, that's correct.
All right, thank you. So at this time, we are going to conclude today's meeting. Again, Toby, Kana, thank you for being here and sharing that with us. I want to thank you all for your participation and engagement in today's meeting. We look forward to seeing you all in August. We will be meeting in San Diego. I hope to promise you a cooler weather there. So we will see you there. Thank you again. Today's meeting is adjourned. Have a great day.